A very good morning to everyone. It's a great privilege and honor for us to welcome you all on behalf of Department of Hepatology, SGPGI, for the 2 days workshop on Hepatology Masterclass on Viral Hepatitis on the occasion of World Hepatitis Day.
World Hepatitis Day is celebrated on 28th of July every year. It is a day for the world hepatitis community to unite and make their voice heard. It is a day to celebrate the progress we have made and to meet the current challenges. It is a day to create awareness and educate people about the effects of viral hepatitis, which can cause liver inflammation, leading to severe liver-related ailments and liver cirrhosis.
This year, the theme is One Life, One Liver, and it is positioned to illuminate the importance of liver to the hepatitis elimination agenda. Now, moving forward, I would like to invite Dr. Amit Goyal, sir, Professor, Head in Hepatology and Course Coordinator for the welcome note. Over to you, sir.
Thank you. I welcome all of you on behalf of our department, along with Dr. Surinder and Dr. Ajay, in this first meeting of its kind, which is on viral hepatitis, celebrating international occasion of World Hepatitis Day, which is celebrated to remember Bloomberg, who discovered hepatitis B virus in 1967. And even the interesting fact is that, and he is the person who discovered hepatitis B vaccine also. So he has discovered both things, virus as well as vaccine. And since then we have made lots of progress. Vaccine is very effective. We know how to prevent it, but unfortunately we don't have any medicine which is highly effective against hepatitis B virus. We can only control virus. We cannot kill the virus forever. We cannot eradicate the virus. So the prevention is the crux. Definitely if you see global level, so World Hepatitis Day is primarily focused on hepatitis B and C. But we have thought that why only B and C? We should talk also about other type of hepatitis, because hepatitis as such is a single entity. So that's why our content include hepatitis A, B, C, and E. D we have left because hardly there is any D in India. And we have also respect the time duration of our course. So I hope that all of you will enjoy and feel free to give your feedback, ask questions. I will come back to you again. We had kept time for introduction of the participant, but just to summarize, I think we have large amount of participation from KGMC, from Integral University, ERA Medical College, Kanpur Medical College, Allahabad, Gorakhpur, and if I am correct, one person has come from Chennai also, and welcome. And we have from Gorakhpur and many more medical colleges. This showed that at least people are interested in this topic. So without wasting time, the entire structure is first we will do few sessions, and meanwhile our director will come along with Dr. Rakesh and Dr. Ambesh, our dean, and Dr. Rajan Saxena. Then we will do inauguration, followed by continuation of our session. After each group of sessions means related to one topic, we will have question answer. You will be given adequate opportunity to ask your question, clarification. Don't take it as a classroom. It is more of an open discussion forum. Wherever you have any doubt, just ask. And we will try to answer. So let us start with the first session. Ria? Sorry. The first session.
Beginning with the session 1, overview of viral hepatitis, I would like to call upon Dr. Ajay Kumar Mishra, Assistant Professor, Department of Hepatology, who will be delivering a talk on concept of liver lobule, photosystem, and liver fibrosis.
I welcome you all to the School of Hepatology. This class will be a very basic class. I think most of us, you are already aware of all these topics, but this will be probably a revision class for all of you to understand better the next sessions. So starting our class, this is a microscopic anatomy of the liver. This is a hepatic lobule, which is a functional unit of the liver. And the periphery of the hepatic lobule, there are portal triads, the bile duct, portal vein, and the hepatic artery. And the center lies the branch of the hepatic veins, that is interlobular vein. In between these portal tracts and the central vein, there is hepatic parenchyma with the plates of hepatocytes and the interspersed sinusoids in between, which carries the blood from the portal tract to central vein. Coming to the portal tract is formed by the three structures, which is bile duct, portal vein, and the hepatic artery. So most of the blood to the liver is carried by the portal vein and followed by the hepatic artery. The blood of the hepatic artery is majorly oxygenated, and the portal vein carries the partially deoxygenated blood. So this is the inflow of the liver, and this is the outflow. The blood there is hepatopetal flow to the liver, and the portal vein carries the blood via sinusoids to the central veins. So this is the flow of the blood. So this part, which is the periportal area, is the most oxygenated part because of the oxygenated blood adjacent to this. And this part, the central vein, which is the pericentral area, is the most susceptible for ischemia because of the decreased oxygenation through these zones. So this will be periportal zone, this will be pericentral zone, and this is the intermediate zone. This is the flow of bile. The bile is produced by the hepatocytes, and through the canalicular circulation, it goes to the bile ducts. So this is the hepatofugal flow of the bile. Coming to the hepatic zonation, as already told, the periportal area is zone 1, zone 3 is pericentral area, and the zone 2 is in between. So these zones have distinct functions also because of the high oxygenation in the periportal zone and those processes which require high oxygen requirement, the oxidative metabolism, gluconeogenesis, and the ureogenesis occur predominantly in the zone 1, and in zone 3 where there is relatively less oxygen, the glycolysis, liponeogenesis, and the xenobiotic metabolism is there, and the transitional zone performs both the functions. So as we see, these zones are distinct but not well defined because the transitional zone is still there. The different pathologies of the liver involve different zones, and this is based on the functions of these zones. We will see later. So why this is important to understand this lobular anatomy, because the different etiologies affect different zones, and histopathology is diagnostic in these situations. We can see the alcoholic liver disease predominantly involves the pericentral area. As we already seen, the xenobiotic function is the function of the zone 3 predominantly. So ALD involves zone 3 predominantly. The NASH, non-alcoholic steatohepatitis, involves pericentral zone, and the chronic viral hepatitis involves periportal and interface areas predominantly. Also, the autoimmune hepatitis also involves the periportal and interface areas. So, the burden of virus is predominantly in the periportal areas and interface areas because of the rich blood supply to those areas. And also, the immune-mediated injury is also predominant in the periportal and interface areas because of the immune-mediated injury in the abundant blood supply. So that's why we need to exclude significant alcohol intake before we diagnose non-alcoholic fatty liver disease. And also we need to exclude viral hepatitis before we diagnose autoimmune hepatitis because of the similar liver injuries in these conditions. Coming to the hepatic portal system, the portal system collects venous blood from the lower esophagus, stomach, duodenum, intestine, and spleen. The normal hepatic circulation is high flow and the low resistance system. Normally there is least resistance, and the blood coming from the GI tract goes to the liver, and from that it goes to the venous circulation of the systemic circulation. The portal system delivers around 1 to 1.5 liters of blood per minute into the sinusoids with the normal venous pressure of 5 to 10 mmHg, and this is around 20% of the whole cardiac output. The portal pressures, if more than 10 mmHg, indicate the portal hypertension. Portal pressure is the product of intrahepatic vascular resistance and portal blood flow across the hepatic vasculature. When the portal pressure increases above the threshold of 8, collaterals begin to develop between the portal vein and the tributaries. So this is the portal circulation. This is the systemic circulation. This is the portal circulation. The systemic circulation from the inferior vena cava and its branches, the portal vein, the left branch, the right branch, and this is the splenic vein. The superior mesenteric vein, the inferior mesenteric vein, and this area is the splenic circulation. The splenic circulation is concerned with the venous drainage to the intestine and the adjacent pancreas and the spleen. So this is basically in cirrhosis. What happens is there is decreased flow to the liver because of the intrahepatic resistance, and there is the hepatofetal flow is reversed. It becomes the hepatofugal. So there is pooling of blood in this circulation, the splenic circulation. So when we treat portal hypertension, the mechanism is to decrease this pooling of the blood in the splenic circulation and to vasoconstrict this splenic circulation so that there is increased blood flow to the liver along with the venous return to the heart. So when if you have seen the patients of cirrhosis, we see that there is altered hemodynamics in those patients. In those patients, since there is increased portal flow resistance, there is decreased end-diastolic volume, and there is decreased blood pressure in patients with cirrhosis, secondary to the decreased venous return. So there is decreased blood flow, and there is a reversal of the blood flow in the splenic circulation. Coming to the varices, the most common varices in the portal, these cirrhotic patients are the esophageal varices. So I have not depicted those varices. These are all the ectopic varices which are formed in the stomach and the lower esophagus. The cardiac varices are formed because of the collateral dilatation on the left gastric vein, and the short gastric vein and the posterior gastric vein predominantly form the fundal varices. The gastroepiploic veins form the isolated gastric varices. Coming to the concept of fibrosis. Fibrosis is basically the response to the liver injury, and it is the healing of the liver parenchyma secondary to the scarring. This is the staging of the liver fibrosis. The F1 stage. The F1 stage is just the expansion of the portal tract secondary to the inflammation and the injury. And in the second stage, there is the portal tracts are connected with the septa, and that is the portal to portal fibrosis. So this is F2. F3 is multiple septa formation between the portal to portal tract and along with the formation of septa between the portal to central. So portal to central along with the portal to portal fibrosis is F3 fibrosis. And whenever there is formation of the nodules along with the extensive fibrosis and the portal to portal and portal to center fibrosis, the bridging fibrosis, this is F4 fibrosis and it is metavir stage 4 cirrhosis. So this is how the liver fibrosis progresses. F0 is without fibrosis, F1 initial, F2 intermediate, and F3 is advanced fibrosis, F4 is cirrhosis. So when we diagnose cirrhosis, it is extensive fibrosis along with nodular regeneration and the distortion of liver architecture. So in the cirrhosis patients, there are two effects, the impairment of the liver function and impairment of blood circulation through the liver. So the obstruction of blood flow through the hepatic globules leads to the increased pressure in the portal vein, portal hypertension, increased pressure in the portal vein, and the manifestation of the collaterals, as we already seen, the varices, along with the exudation of fluid in the abdomen, ascites, and the congestion of venous system, splenomegaly, and pancytopenia. So this is the basic I wanted to tell. This is, I think, it will be easier to proceed with. Thank you.
Basically, if we carry home message with this session, that blood flow of liver is 1500 ml per minute. That means 25% of total cardiac output is taking liver every minute. That is one important message. Second, you can say that the 2/3 or 3/4 of the blood supply to liver is not arterial, it is venous blood. It is coming from portal venous system, which is not giving oxygen, which is giving nutrition to the liver, because all the blood is coming from the GI tract. Only 1/4 of the blood is arterial, which is giving oxygen to the liver. So liver, you can say, is prone for ischemic injury, right? Second thing is why it is called portal system. That is important point which we should know. And where the portal system are, where the blood is collected from capillaries and again going into capillaries. Otherwise, blood after being collected from capillaries goes to heart. But here the blood is collected from capillaries in lumen and then going to the capillaries inside the liver. That is called a portal system. And the second portal system in our body exists in our brain, pituitary, hypophyseal pituitary system. So there are two portal systems in our body, right? So these are the few things. And what is called the fibrosis F1, F2, F3, F4, it is a continuation. We might say it is F1, F2, F3, F4, but pathologists will tell it better that actually it is a continuous process. We have made it 1, 2, 3, 4 just for ease of understanding and discussion so that we can communicate to each other. But actually it is a continuous process. So whatever is it F4, actually it is a cirrhosis. These are the few important points from this session which I wanted to communicate. Yeah.
Thank you, sir. Now, I would like to call upon Dr. Amit Goyal, sir, who will be delivering a talk on interpretation of liver function.
Thank you. So liver function test, second basic concept for hepatology or viral hepatitis, whichever we read. Liver function test, we all know, set of investigation, bilirubin, SGOT-PT, alkaline phosphatase, GGT, albumin, and prothrombin time. We think that sometimes that entire LFT is one investigation, but actually every component of LFT is giving you some different information. Out of which first I will talk about the bilirubin, then other component. And so before we move to the bilirubin, we should know the pathophysiology, how bilirubin is produced. It is produced by the destruction of RBC, and from there what bilirubin is produced, it is an unconjugated bilirubin. Then it is taken up by the liver and it will be conjugated. conjugated bilirubin is excreted by liver into the system, and where it is excreted is an important point which you should know. You can see I have intentionally kept this line is thick and this line is thin. In normal condition, most of the conjugated bilirubin is excreted in the biliary system, from where it goes down into the GI tract. That is the normal pathway, and then it goes for the recirculation, enterohepatic circulation from small intestine. But if there is any problem, any obstruction here, then this line is thinned up and this line is thickened up, and then the conjugated bilirubin goes into the systemic circulation. And that's why whenever we see report, then what is the conjugated fraction, what is the unconjugated fraction, that helps us that where the problem is. So based on this bilirubin metabolism in one slide, you can see there are three types of disorder which can cause jaundice. First can be the increased destruction of RBC, where we know it is hemolytic jaundice. Second could be the abnormal function of liver, means liver failed to take up the unconjugated bilirubin or failed to excrete the conjugated bilirubin, and that is called hepatocellular jaundice. Third, the problem could be in the biliary tract because of obstruction, which is called obstructive jaundice. So this is the entire basis of three types of jaundice, which is hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. Now coming to the other component of liver function test. So before we move ahead, we should know this is the hepatocyte, this is the sinusoid. Plates of hepatocytes are lying like this, parallel to each other, and the two hepatocytes are joined with each other at this side, which is called bile canaliculus. So here, these bile canaliculus keep on joining and getting bigger and bigger and form the bile duct, which we had seen in the last slide. So from here, liver is taking nutrition, etc., which is coming from the blood and excreting through the biliary tract. Now, this is an important slide which will help you to understand entire component of liver function test. This component is cytoplasm, it is mitochondria, and this is bile canaliculi. ALT means SGPT, it is located in cytoplasm. That is why I have written it there. Mitochondria, we can see there are two enzymes written, LDH and AST. So these two enzymes inside the hepatocyte are primarily located inside the mitochondria. The site of position of enzyme will determine basically where the injury is, and that will help you to understand the level of elevation. And alkaline phosphatase and gamma GT are located here in bile canaliculus membrane. So now you will know that every component is telling you a different type of information from a liver cell. So if there is injury to the liver cell, obviously the first injury will happen to cytoplasm, and cytoplasm will be released, and ALT, AST will be released. But AST is located deep into the mitochondria. So if the injury is superficial, minor, AST will not be elevated, but ALT will elevate very fast, and that is why ALT is more sensitive, more specific for liver injury than AST. If there is injury to the biliary tract, obviously pressure will build up in the biliary caniculi and the enzyme will be released, and so we will have alkaline phosphatase and gamma GT elevation. If there is long-term injury, then AST will be more elevated than ALT, and that is why in most of the cirrhosis patients we find that AST is elevated more, yeah, ALT-AST ratio is reversed, what is typically known as. Because whenever there is long-term injury, AST will be elevated more. One of the reason is AST after production, it is cleared by the endothelial cell which are lining the sinusoid of the liver. And whenever there is cirrhosis or fibrosis, the sinusoid cell blood circulation is not normal. Those are bypassed. So AST is not cleared from the sinusoid, and that's why AST goes up. And if there is alcohol specifically damage to the mitochondria, then we have AST elevation. Why? What alcohol does? It causes uncoupling of oxidative metabolism inside the mitochondria. So mitochondrial toxicity, and that's why in alcoholic cirrhosis, alcoholic liver injury, AST is more elevated than ALT. Right? So with every component of LFT is giving you different set of information, and you can interpret it accordingly. Then another function is synthetic function of liver. Two important components, which are the components of liver function test, is albumin, and second part is clotting factor, prothrombin time. So these two functions are giving you information how much is good is the synthetic function of liver. It is not giving you information how much is injury to the liver. Synthetic function specifically, albumin and prothrombin time. So if we summarize, total bilirubin and conjugated bilirubin fraction, they are telling about the conjugation capacity of liver and the excretory capacity of liver. ALT, AST, they are telling about the injury, how much injury to the liver is. Because if superficial injury, ALT will be more elevated. If prolonged injury or consistent injury, deeper injury, then AST will also be elevated. Alkaline phosphatase and GGT, they are telling about the biliary tract injury. And albumin and prothrombin time, they are giving you information about the synthetic function of liver. So every component of liver function test is giving you a different set of information. And that's why probably when we are monitoring or following our patient, we need not to test every component of LFT, just we need to monitor a specific component of LFT. So whenever we have LFT derangement in our patient, we have to how to approach this patient. Now, after going this much of basic information, we will approach a patient with LFT derangement. First, we have to see whether bilirubin is primarily elevated or not, or enzyme is elevated. If enzyme is elevated, there can be two possibilities: whether ALT/AST is primarily elevated or alkaline phosphatase is more elevated. So we can have three types of condition: 1, 2, and 3. Each will be taken separately. First, we are seeing that bilirubin is elevated. Then in bilirubin component, we have to see whether conjugated bilirubin is elevated or unconjugated is bilirubin is elevated. If conjugated, then it can be disease of liver, means hepatocellular jaundice, or it can be disease of biliary tract, but it cannot be a disease of hemolytic system, right? So we can do an ultrasound. Ultrasound will help you to exclude biliary obstruction. If biliary obstruction is excluded, you are left only with hepatocellular jaundice. So with this much basic information, you can conclude based on LFT pattern and based on ultrasound that the patient is having hepatocellular jaundice. Cause could be anything. If no biliary obstruction, then there could be different possibilities, which I will not go into the detail. Then if we have enzyme elevation and ALT/AST is elevated, it is not the ratio, it is ALT or AST. Most of the time you focus on ALT elevation, basically. You can read it as it is. There can be extrinsic causes which are reversible, like alcohol, obesity, hepatotoxic drug. The most common hepatotoxic drug are anti-epileptic drug, anti-tubercular drug, and estrogen. These are the three most common group of drugs, sometime NSAID also. There could be viral hepatitis, which we are going to deal in depth, and that's why it is making a background. Then there can be intrinsic causes like autoimmune hepatitis, genetic disorder, which are more in domain of hepatology than journal physicians or at MD level teaching. Then we can have alkaline phosphatase elevation. We can see the ratio of ALT elevation versus alkaline phosphatase ratio, and using this approach, we can reach to some conclusion that my patient is having cholestatic jaundice or hepatocellular jaundice or mixed pattern, because each cause is giving a specific type of jaundice pattern, and that will help. I will not go in detail on these things because then it will become more of hardcore hepatology than general viral hepatitis. So if you have alkaline phosphatase elevation, first thing we have to see GGT elevation. If GGT is normal, that means this alkaline phosphatase, the source is bone, not the liver. So if GGT is normal, it is a non-hepatic cause. We have to look for some other source of GGT, alkaline phosphatase elevation. If GGT is elevated, then we have to do ultrasound again to exclude biliary obstruction. If biliary obstruction is not present, that means it is non-obstructive cause for cholestasis. The causes could be many more. So it is a general overview, general approach, how you can understand. So most important investigation is the what fraction of bilirubin is conjugated. Second, what is the ultrasound finding? Third, whether alkaline phosphatase is elevated or not. If alkaline phosphatase is elevated, whether GGT is normal or not. These four investigation will take you to some reasonable conclusion that which type of disease you are dealing with. just to differentiate that ALT, AST, most of the time we take it as a single investigation. There are two different investigations. They have marked difference between the two different enzymes. ALT is located primarily liver and very small amount in kidney, right? And probably that is one of the reason in chronic kidney disease patient, ALT level is markedly normal or low because the kidney source of ALT has gone. There are two sources. But in AST, we have other sources. The biggest source is RBC and muscle. Liver is not a big source of AST in the serum. Because of different location and widespread location, AST is less specific investigation than ALT. ALT is located in cytoplasm, AST is located in mitochondria. As I have explained earlier, that means to release AST from liver, you need a higher degree of injury. But to release ALT, you just need minor degree of injury, any form, because it is superficially located inside the cytoplasm. And ALT have a half-life of 48 hours. AST has 18 hours. So what does it mean half-life? Half-life means once ALT has gone up, it will come down much more slowly, but AST will come down very fast. So if you follow your viral hepatitis patient, AST goes up, but it will come down very fast in a week or two, but ALT will continue at high. So sometimes we may get confused that why there is a discrepancy between the two enzymes. This is the reason for discrepancy, that why one enzyme is not coming down. Whenever we are dealing with ALT, AST, which we must understand that its level is affected by affected by some factor like age, gender, nutrition status, food intake, exercise, and delay in sample processing. Why by age? Because age is affecting the muscle mass, and muscle is a source for AST. Age will affect blood volume. RBC is a source for AST. Age will affect the liver volume to some extent, very little, not much, and liver is a source for ALT. So age is an important factor. Gender, again, the muscle mass is different between the male and female, so the AST level will be affected. Nutritional status, again, the muscle mass and RBC count will affect, so this will be affect. Food intake, obviously, when you will take food, liver will be exposed to lots of toxins and products coming from the gut. So the machinery of liver will start working, some degree of injury will happen, and ALT level will go up. That is why LFT is always advised to test in fasting condition. Exercise, because of muscle is the source, muscle injury will happen when you do exercise and AST will be released. And delay in sample processing, because whenever there is a delay, AST will be released from the RBCs and they will falsely elevate the serum AST level. And if you cannot correct for the age and gender as of now, but and nutrition, but you can take care of food, exercise, and delays, three major factors. And that is why typically is advised that LFT should be tested after overnight fasting in the morning condition, in the morning time, because at that time exercise will not affect, fasting will be taken care of, and always whichever sample is reaching lab in early morning hour are definitely processed on the same day. If sample is reaching 2 o'clock in the lab, there is a chance that the sample will be left in the lab for next day processing. So delay in processing will be taken care of. And that is why typically it is taught that LFT should always be given in the morning hour instead of giving in the evening or night. So reference range is important concept, because classically we consider that 40 international unit, and still we are also practicing 40, but now it is changing everywhere. You may find that 18, 28, 26 different level. I will not go in all those details. You can take still 40 is important. What I want to give message in this slide is, whenever there is a elevation of ALT or AST, don't take it the absolute value. You take it how many fold it is elevated from the baseline. If you take 40 as the baseline, then 120 should not be taken as 80 unit elevation. It should be taken as 3-fold elevation. So whatever number is, divide it by 40, and then that is more important in present era of management of liver disease than absolute elevation of ALT-AST. And this is another important message, that ALT-AST level does not correlate with the severity of liver injury. It is an indicator, but it does not correlate very well with the degree of liver injury. And yeah, important. It has nothing to do with serum bilirubin level. In typically viral hepatitis patient, you will see that bilirubin continues to go up, but OTPT comes down. These two things have nothing to do because of very different. Bilirubin is giving a different function. SGOTPT is giving a different thing. That is why they are not correlating with each other. Ratio, ELT-ST ratio, we were being taught during our MBBS day, but in present era, it is not of much use other than few of these conditions. Alcoholic liver disease, as I discussed, because of mitochondrial toxicity. Wilson disease, why in Wilson disease? Anyone? Why in Wilson disease AST is elevated than ALT? Because of hemolysis. Because of hemolysis, right? Liver cirrhosis, again, I have explained why AST is elevated, because it is not cleared from the sinusoidal cell. Non-hepatic cause, hemolysis, muscle disease, and heart disease with sources for AST. So these are the conditions where AST can be elevated than ALT. Albumin is not a marker of acute injury. It is a marker of chronic injury. Chronic injury, always. If albumin is low, there can be 2 or 3 most common cause. One could be the chronic liver disease. Second could be the nutritional status. And third could be the albumin loss. Loss could be through urine or through stool. So these are the 3 common causes for low serum albumin. Prothrombin time, this is very interesting investigation, which we always barge upon in our day-to-day practice every day. This is the one liver function test which is deranged last. Whenever there is liver injury, this is the investigation which will derange at the last. It will remain intact. This is the last, you can say, army man. So this will be destroyed at the last and it will recover first. So if we have to monitor a patient, that is why when we will talk about ALF, we will focus that please monitor only and only INR, no other investigation. This is the investigation which will go last, back, and recover first. These tests are of very limited value. Just I have included because we keep on reading these things in our textbook, but we never do these tests, and they have very limited value. LDH have value only in one condition in hepatology, and that is ischemic hepatitis, where LDH is very high. So in summary, liver function test is not a single test. It contains lots of components. Every component is telling about a different information, and one information has very limited thing to do with the other one. So we have to read and we have to decide what we need to see in this patient. Albumin is an indicator of chronic injury. ALT, ST, they are more marker of acute injury. AST is more in favor of chronic injury. Prothrombin time is the last investigation to derange and recover fast in patient with liver injury. So if there is any question, we can answer. Otherwise, we can move to the next question. How many times? Most of the time, actually, usually what we take is minimum 2-fold elevation. And what is important is not the degree of elevation. What is more important is consistency of elevation. Even if it is 60, but you have repeated it on several occasions over 3 months, and every time it is elevated, that is more important than a single elevation. So because LFT means most of the time is SGOTPT. That's what I'm telling you, because that is what is in terms of fold elevation. So consistency of elevation is more important than the quantity of elevation. That is one. And if you have to see the quantity, then 1.5 to 2 times is 2 times you can say safely. That is most of the time because of poor nutrition. because they will come to you by the 20 days, 25 days is crossed. If you see here, that answer is here. Half-life of albumin is 21 days. And by the time they are coming to us, is always 3 weeks have passed, and their nutrition has grossly gone down, and that is why albumin is low. It is not because of liver, because of 21 days.
Thank you, sir. Next, I would like to call upon Dr. Sumit Jungtha, who will be delivering a talk on methods for the assessment of liver fibrosis. Sir, please.
Good morning, everyone. I would like to thank Professor Amit Goel and Dr. Surendran Ajay for giving me this opportunity. I will give my talk on method of assessment of liver fibrosis. I will cover my topic in following headings: introduction, pathogenesis of liver fibrosis, modalities for assessment of liver fibrosis. It will cover invasive as well as non-invasive tests. Liver fibrosis is a natural response to chronic liver injury. It results in abnormal connective tissue production and deposition in the liver. Accurate assessment of liver fibrosis is essential to predict prognosis and for the therapeutic decision. Liver biopsy is considered as the gold standard to classify liver fibrosis, but there are many limitations for liver fibrosis. So there is a need for development of another way to assess the degree of liver fibrosis. Because liver biopsy is invasive, it requires expertise to perform and interpret. It having risk of surgical complications like hemorrhage. It may cause sampling error occur, and interpretation is difficult because inter and intra-observer variability may occur during the interpretation of liver biopsy findings. This is the pathogenesis of liver fibrosis. Various agents like hepatitis B, hepatitis C, alcohol, NASH, and some metabolic diseases causes liver cell injury. It leads to inflammation and activation of hepatic stellate cells. Hepatic stellate cells leads to activations of myofibroblasts by these mediators, and myofibroblast activation leads to increased deposition of collagen, elastin, and it will lead to fibrosis and development of cirrhosis. So, liver fibrosis occurs due to imbalance between the factor that stimulate hepatocyte destruction and fibrogenesis and factor that stimulate hepatocyte regeneration. There is increased production of these factors and decreased production of these factors lead to liver fibrosis. So diagnosis of and staging of liver fibrosis may be done by liver biopsy, conventional imaging, by serological markers, serological panels, shear wave elastography, and by some emerging techniques. As I told earlier, liver biopsy is the gold standard, widely used method to assess the histological fibrosis. Liver fibrosis progresses from F0 to F4. F4 is considered as cirrhosis and F0 is no fibrosis. This is the meta-phase fibrosis staging system. F1 is initial fibrosis that progress into F3 and F2 fibrosis. F0 means According to Metavary staging system, F0 is no fibrosis. F1 is portal fibrosis with septa, without septa. F2 is portal fibrosis with septa. F3 is numerous septa without cirrhosis, and F4 is cirrhosis. As told earlier by Dr. Amit Goel, fibrosis in the liver is not discrete phenomena. It is a continuous process. We have F3, F4, F2 fibrosis in the same liver. So it is not a discrete phenomenon. Another scoring system is Isaac scoring system. In Isaac scoring system, it is not very widely used because it is difficult, but F0 is no fibrosis. In Isaac stage 1, fibrosis expansion occurs to some of the portal area. In Isaac stage 2, fibrosis expansion occurs to portal area with some fibrous septa. In Isaac stage 3, fibrosis expansion to most of the portal area with some portal to portal bridging. In stage 4, there is some portal to portal along with portal to central bridging. Isaac 5, there is mark bridging, and Isaac 6 is cirrhosis. These are the serological marker. Because liver biopsy cannot be done in all patients, so we have to develop other markers for the assessment of liver fibrosis. So we develop direct test and indirect test. Direct test reflect directly extracellular matrix metabolism, and indirect test reflect the change in the hepatic function. For the assessment of fibrosis, direct biomarkers are like type 1 and type 4 collagen, laminin, hyaluronic acid, and procollagen type 1 carboxy terminal peptide. But these direct biomarkers are not used widely. We use indirect marker for assessment of liver fibrosis like serum AST level, platelet count, coagulation parameters, GGT, total bilirubin, alpha-2 macroglobin, and alpha-2 globulin. There are various serological panels made for by combination of these indirect serological markers. Commonly used tests are EPRI, FIB4, and Fibro test. EPRI is very important indirect serological marker, which is widely used. It is a ratio of AST and platelet. AST platelet ratio index is EPRI. EPRI is calculated by dividing upper limit of AST level in the patient divided by upper limit of the AST, which is usually considered as the 40. It is divided by platelet count. Platelet count, if any patient is having platelet count is 1,50,000. So we put the value of 150 in the platelet count. First 3 digits are important. If platelet count is 80,000, then we put this value is 80. It is multiplied by 100 so that we calculate easily the EPRI score. Another one is the FIB4 score. It is a ratio of AS multiplied by AST divided by platelet count and under square root of ALT. Its calculation needs calculator. It is not easy to calculate, but it is more reliable in comparison to EPRI score. We put the cutoff of EPRI score and FIB4 score. If EPRI score is less than 0.5, then it is considered that liver is normal. It doesn't have significant fibrosis. Either liver is having no fibrosis or F1 fibrosis. If EPRI score is more than 1.5, then fibrosis is more than F2. Patient is having a significant fibrosis. And if EPRI score is less than 1, then chances of having cirrhosis is very less. And if EPRI score is more than 2, the chances of cirrhosis is very high. For the FIB4 score, only cutoff developed for the significant fibrosis. Lower cutoff is 1.45 and higher cutoff is 3.25. Use of single cutoff for EPRI and FIB4 results in suboptimal sensitivity and specificity. Hence, 2 cutoff were kept for these calculations. High cutoff has high specificity used to diagnose fibrosis at a particular stage, and lower cutoff has high sensitivity used to rule out presence of particular stage of fibrosis. This is the chart showing sensitivity and specificity of various indirect serological markers. Sensitivity of EPRI is about 57% and specificity is about 93%. For the FIB4 index, sensitivity is about 65% and specificity is about 97%. We can use conventional imaging for the diagnosis of fibrosis, but in conventional imaging, we can diagnose fibrosis usually at the later stage when patient develop cirrhosis or very advanced fibrosis. The findings of significant fibrosis or cirrhosis on conventional ultrasounds are shrunken and nodular liver, dilated portal vein, splenomegaly, and collaterals. If a patient is having collateral, these are the most important findings of the ultrasound to diagnose the significant fibrosis or cirrhosis. Coarse ecotexture of the liver, which is usually written in the reports, is having no value or very less value. Following it, there is development of one more non-invasive test, that is shear wave elastography. Shear wave elastography provides quantitative measure of stiffness by using acoustic or mechanical pulses induced by the ultrasound machine. It includes transient elastography, acoustic radiation force impulse imaging, and two-dimensional shear wave elastography. This is the comparative chart between the transient elastography, ARFI, and 2D shear wave elastography. Most commonly used method is transient elastography, also called fibroscan. It uses shear wave imaging to estimate liver stiffness. It is advantages, various advantages like accurate diagnosis of cirrhosis, can be used in physician at the bedside, it is portable and requires short procedure time for immediate result. But there are some problems with the fibroscan, like it is difficult to interpret or do the fibroscan in very obese patient, and if the patient is having ascites, there is chances we are having difficulty in the finding of the fibroscan. So another problem is in the fibroscan, it is costly machine, not available at every center, and we cannot localize the exact site by this fibroscan. So for that we can use AFRI, in which user ultrasound, so we can see the morphology also, and we can localize the site from where we are assessing the disease process. But these two methods are not very well validated and not used commonly. Fibroscan is the most commonly used non-invasive test for assessment of liver fibrosis. Transient elastography is most extensively studied and validated imaging technique with high intra and inter-observer reproducibility. Transient elastography better to ruling out cirrhosis than ruling in cirrhosis. That means negative predictive value of fibroscan is higher is comparison to positive predictive value. In the transient elastography, transducer send a mechanical shear wave that penetrates the liver, and returning wave velocity can be recorded by this transducer, and velocity of this returning wave differ according to liver stiffness. So by this we can measure nearly about 3 centimeter cube area, that is nearly about 100 times more than the sampling area which is done by the liver biopsy. We can measure cap value and stiffness value by the fibroscan. Fibroscan value showed by two things. One is the E value, that is fibrosis value. This is the fibrosis value. This is the cap value. Normally, when we see the report of fibroscan, this type of picture come in. So it is important to know how to interpret the fibroscan value. Cap value shows steatosis in the liver. So cap value is less than 260 is S1. 260 to 290 S2 and more than 290 is S3. How we can know the report of the fibroscan is accurate or it is accurate or not? So median is calculated from the 10 valid measurement and it is used as the final result. Interquartile range is the spread of middle half of the observation. It should be small. And IQR upon median ratio is very important. It indicates variability in different reading. High value means large variation, and if it is more than 30%, implies no reliability. Some are the limitations of fibroscan, like if serum aminotransferases levels are normal, value may be different. So for the important accurate measurement of fibroscan, IQR upon median value should be less than 30%. Serum aminotransferase level should be less than 5 times of upper limit of normal. There is absence of extrahepatic cholestasis, absence of congestive liver failure like right heart failure, and absence of ongoing alcohol intake. A patient should be in the fasting state. These are the various value of the fibroscan. This means according to etiology, interpretation of fibroscan value changes. For the F4 fibrosis in the hepatitis B, if patient is having value more than 11, it is considered as the F4 fibrosis. But in the cholestatic liver disease, for that value of fibrosis score should be more than 17. If patient is having value of fibrosis is more than 19.5, there is high probability of varices. And if value is less than 17, then low probability of clinically significant portal hypertension. So advantage of non-invasive tests are easy to perform, free of complications, widespread availability, can be done in outpatient setting, do not require specialized training, homogeneity because of automated measurement of their component, and easy to repeat at frequent intervals. There are some emerging genetic markers like alteration in intracellular mRNA, its role in pathophysiology of chronic liver disease with different etiology. MicroRNA 9, 21, and 88 activation leads to activation of myofibroblast and synthesis of extracellular protein and collagen deposition. Broad variety of mRNA are involved in liver fibrosis and enter into systemic circulation that can be used as a potential biomarker for assessing liver fibrosis. Thank you. Any question?
So now we will move to the next session, but if you have any question related to the previous 3 sessions, we can solve it. या तो किसी को कुछ समझ में नहीं आया या सब कुछ समझ में आ गया, दो ही हो सकता है, नहीं सर? या
cut off for ASP and ALD now they are like those that they have been revised. So
yeah, why not you come here and tell so that everyone can take it.
So previously the normal cutoff was 40 as you showed, but now they have been revised. Some say that 35 for males, 25 for females, or 30 for males and 19 for females. So then it will be very difficult because if we see our patients for autoimmune hepatitis, those who have come with 2 to 3 times or 5 times more the level of validation. And whenever we see the response, we take 40 as cutoff. So for biochemical revision, to be achieved, the normalization of AST/ALT is required. So if we take this new cutoff, new or lower cutoff, it will be very difficult to say that patients are in remission. So most of the patients achieve this AST/ALT level only 30, 35 or plus 40. So what are the thoughts on that?
Oh, see, this new cutoff is more in vogue in hepatology field. If you see if you go beyond hepatology, in general practice, nobody is thinking about 19, 35. Everyone is still taking, like, we can vote. How many of you taking that, what is the normal level? 40. You can raise your hand. Everyone is still taking 40. So this is more of a thought process related to hepatology, because we are trying to tear between our hair. ये बाल की खाल निकाल रहे हैं हम लोग, ये उसका ज्यादा इस्तेमाल है. लेकिन the more important thing what I told is consistency of elevation, how consistent this enzyme is elevated. That is first point. And second is how many fold it is elevated. If you take 40, even then it is 3-fold elevation or 2-fold. If you take 30, then how many fold it is. So whatever you take as baseline, then you calculate as the fold elevation, and you monitor your response in terms of fold response. Yes, sir. Please come here, sir. Yeah.
Would you think that this recent change kept the tax from for lower ASP disease? It is something very similar to the phenomena that occurred in diabetes, that the incidence of diabetes population has multiplied. The whole globe is going to become diabetic at a point of time, and change is happening in hypertension. So is this low cutoff and industry driven exercise with little medicine into it, more of full idea?
Exactly, it is what sir is telling indirectly. Probably it is partially driven by the industry. If you lower the cutoff level by 2 international units from 40 to 38, millions of people will become having the deranged LFT, and they will be taken in the pool of fatty liver disease. So see, the number of patients who will need treatment and consultation will increase markedly. So this is one of the hidden point what sir is telling is exactly. So probably still we should live with 40, and we should focus more on how consistent it is elevation and how many fold it is elevated. So if it was taking 40 and it is coming down 3-4, coming down to 40, it's fine, comfortable. So 40 should be still practically acceptable.
I'd like to add something to it. As far as the hypertension game is concerned, the best of my knowledge, the more position we are at, if coming a study on blood pressure, which I read that I'm a very good and almost like 40 years of longitudinal follow-up of the population. You will use the solution, which could you input check for all the 50 years that we have seen. Currently, the definition of hypertension. Now, the basis of taking is not the strong longitudinal study. If you look at the basis of bias in blood pressure, why the because that suddenly changed. The legal student 120 passes that was considered to be normal, right? And diabetes related mortality in those periods was not very high. Now they have reduced the sugar level, mortality is even higher. Right? So there is something where we as doctors are going wrong. And this session on fibrosis is singularly important. Everything which is relevant in the field has been shown. That is important. If you got all the knowledge that you could take off, what all adds up to adding liver fibrosis. This morning I was reading about the lecture that Dr. Farid delivered in Parliament Day, on World Hepatitis Day, and his figure is even more stunning. That every third person in India has a fatty liver disease. Only 2 months ago, or 3 months ago, we had a figure showing that 45% incidence of fatty liver disease in India at large. It has suddenly. So where are we heading? Look at us.
It is because of ultrasound, it is better quality of ultrasound machine, that is more important. So now we will move to the inauguration session. Thank you.
We are moving to the inaugural session. I would like to invite our honorable dignitaries, Professor R.K. Diman sir, Director, SGPGI Lucknow, Professor S.P. Ambesh sir, Dean, SGPGI Lucknow, Professor Rakesh Agarwal sir, Director, JIPMER Puducherry, Professor Rajan Saxena sir, Nodal Officer, CHBDP. I would like to request my colleagues Geeta and Arifa to present flowers to our chief guest. Now I would like to invite
राजश्री सोल से सारे अपडेट्स पाने के लिए बेल आइकन दबाइए।
I would like to invite on that. Please come forward.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा। हस्ते स्फाटिकमालिकां
Now, I would like to request Professor R.K. Biman sir to share his thoughts.
Professor Rakesh Agarwal, the Director, JIPMER Pondicherry, Professor S.P. Ambesh, the Dean of the Institute, Professor Rajan Saxena, Head of the Department of Surgical Gastroenterology, my other colleagues, students, ladies and gentlemen. First of all, I will congratulate Professor Amit Goyal and his team for organizing this symposium on World Hepatitis Day. As far as the World Hepatitis Day is concerned, basically it is
celebrated or to give the importance of the viral hepatitis in our society, in our state, as well as at the nation also. You all know there are several types of the viral hepatitis. One is born through the water, hepatitis A and E. Other, either the percutaneous or blood-borne, many other routes also, hepatitis B, C, and the D also. As far as the hepatitis A and E is concerned, they do not become chronic except in certain circumstances, but largely they have the acute course or sometimes the fulminant course also. On other hand, hepatitis B and C, they become chronic, as you all know. Hepatitis C approximately 70 to 80%, and hepatitis B approximately 5% or more. So, and many of these patients who becomes chronic, they lead to complications. One is that they have increasing fibrosis and ultimately become the cirrhosis of liver. The first compensated and then decompensated also. When I say the decompensation, 3-4 things we have to remember: bleeding, ascites, hepatic encephalopathy, and many infections also. So once the person goes to this stage, cirrhosis and the complication and the late complication, hepatocellular carcinoma also, then the cost of the treatment is very much actually expensive, very expensive, and is not cost effective. Vis-a-vis, if we detect these infections early in the course and treat them if required. For example, if see the hepatitis C, you can treat all of the infection who are viremic. On other hand, there are certain guidelines for the hepatitis B to treat. Not all patients require the treatment also, but certainly they require the follow-up for complications such as the hepatocellular carcinoma. So what I'm trying to say, as far as you have to reduce not only the prevalence, but most importantly, you have to go for the incidence also, that should be reduced also. And our society should become these viral infection free also. And you all know that we are running a national viral hepatitis control program. And there is one booklet that has been published by the Department of Health and the Family Welfare at the center also. And they have given the guidelines also how to go about it, but the main emphasis is already on early detection and the treatment also. The question of the early detection is really a challenging for all of us also, and that's why that these kind of the symposium and awareness program has to be done at all levels, be it at the physicians, specialists, or the general public also. And if you see between these two viruses, at least one is preventable. That is the very effective vaccines. They are effective more than 97% of the time if they are given to a person. I think we have to exploit this thing also as far as the vaccination of the hepatitis B is concerned. And similarly, hepatitis C virus also. It is not that we have to give the injection as we used to give previously, interferon in the riverbrain also. But now we have very short courses of the 8 weeks or 12 weeks with the oral antivirals also. I think you are going through the various aspects of these viruses. I think starting from the epidemiology, virology, early detection also, and the diagnostics also, and the treatment guidelines, which are very, very important also. If I see the many of the times for the hepatitis B virus, those who even don't require the treatment, they are being given because the drug is very cheap. So you have to learn which person is required, or really require the treatment. So this is something you have to learn over here, and that is very important. And practice also wherever you are, those guidelines and the guidance also. And with these words, I would like to stop over here. And thank you very much, making me the part of this symposium also. And I'm really grateful that Professor Rakesh Agarwal has come. He belongs to this institute also, Department of the Gastroenterology. And I would like to share one thing. Then when I was doing my DM over here, he was already a consultant here. So you can say that in all way that he was my teacher at this very institute when I was doing my DM. And with these words, I stop here. Thank you so much.
Thank you, sir. Now, I would like to invite Professor S.P. Ambedkar, Dean, SGPGI, to say a few words.
Professor R.K. Dhiman, Director, SGPGIMS. Professor Rakesh Agarwal, Director, JIPMER, Puducherry. Professor Rajan Saxena, Head Department of Surgical Gastroenterology. Esteemed guests, speakers, my faculty colleagues, residents, ladies and gentlemen. As we know that for the last 30 or 35 years, we are just gradually progressing towards the epidemic of hepatitis. Every year, millions of people contract hepatitis and millions of people die. अगर मैं पुराने 2015 का WHO के डाटा की बात करूं तो करीब 14 लाख लोग हेपेटाइटिस बी की वजह से they lost their life. और 2019 का जो डाटा है तो that is somewhere around 20 lakhs. मैं इसको डाटा को मैं कहूँगा ये अंडर एस्टिमेटेड डाटा क्योंकि मोस्ट ऑफ द पेशेंट्स रिमेन अनडायग्नोज्ड. Unfortunately, there are some countries like African countries, Latin American countries, they have huge number of hepatitis patients and overall incidence somewhere around 5 to 6%. That's very high. Fortunately, we can say in India, the incidence is, according to WHO 2019, the incidence is 1.8 to 2.5%. But on other part, I would say that we contribute huge number of hepatitis patients of the world because of our massive population. So that is very important. जो अभी का जो 2019 का फिगर है वो 30 करोड़ हेपेटाइटिस पॉजिटिव पेशेंट्स का है 2019 WHO का. 30 करोड़ पॉपुलेशन is suffering with hepatitis B and 6 crore population is suffering with hepatitis C. Again, I would say this is again underestimated. Actually, आज हम वर्ल्ड हेपेटाइटिस डे मना रहे हैं तो मैं थोड़ा सा इसके हिस्ट्री के बारे में जाऊंगा. Experts from hepatology and gastroenterology from worldwide, they met and they formed a World Hepatitis Alliance in 2007. And just to make aware the public about the problems of hepatitis, they decided to celebrate or to observe a day for World Hepatitis Day. May 19, 2008 को फर्स्ट टाइम वर्ल्ड हेपेटाइटिस डे मनाया गया और उसके बाद में 2 साल ये मनाया 8 और 9 को, और 2010 में WHO ने कहा कि लेट्स सेलिब्रेट इट एज ऑन 28 जुलाई and give the honor to the great American scientist and physician, Dr. Baruch Samuel Bloomberg. He was born on 28th of July. And since then, we have been celebrating World Hepatitis Day. And today, of course, we are one day late because the Department of Hepatology decided to celebrate as a Hepatitis World Weekend, in fact, so that you can cover and give the more message to the colleagues, residents on the hepatitis. तो इस बार हम ये 16वां वर्ल्ड हेपेटाइटिस डे मना रहे हैं. एंड इसका जो अल्टीमेट WHO का जो अल्टीमेट गोल है, दैट इज टू मेक द वर्ल्ड फ्री ऑफ हेपेटाइटिस बाय 2030. 2030 तक हमको हेपेटाइटिस एलिमिनेट करना है. और बिकॉज ऑफ दिस, in 2023, the theme of World Hepatitis Day is we can't wait. We can't wait for the screening of the expectant mothers. We can't wait to immunize the newborn and the children. We can't wait to give the medications or treatment to the people who are suffering with hepatitis. And we can't wait for the mass screening. So this is the motto, this is the goal of today's or theme of today's World Hepatitis Day. मुझे खुशी हो रही है इस बात से कि डिपार्टमेंट हेपेटोलॉजी 2021 में फाउंड हुआ प्रोफेसर धीमन के एफर्ट्स की वजह से, और हम इसमें लगातार प्रोग्रेस कर रहे हैं. जहां तक थोड़ा सा मैं डॉक्टर अमित गोयल, प्रोफेसर अमित गोयल को मैं कहूंगा कि हमने प्रोग्राम बहुत अच्छा डिजाइन किया है. 2 दिन का सारी चीजें कवर की हैं, हम हेपेटाइटिस ए टू हेपेटाइटिस बी, सी, डी, ई, even hepatitis in HIV patients, hepatitis in tuberculosis, hepatitis in renal failure patients. We have covered the topic, I mean, everything very well. But overall, जब भी हम कोई डे मनाते हैं, वर्ल्ड डे मनाते हैं, तो उसके 3 पर्पस होते हैं. फर्स्ट पर्पस जो होता है, टू एजुकेट द मासेस. I would have been much happier if you had included some of the public people or the patients or their relatives to educate them, because हमारा पर्पस इस डे का होता है कि पब्लिक को हम अवेयर करें about the problems, about this infection, how this disease can be diagnosed, how this disease can be treated, how they can be counseled. So वो सारी चीजें थोड़ी सी उसमें अगर होती तो मुझे और अच्छा लगता. दूसरा, ऑफ कोर्स, मीडिया कवरेज आप बाद में दे सकते हैं, बट मीडिया पीपल शुड हैव बीन हियर. हो सकता है कुछ हो, आई डोंट नो. तो तीसरा है, एक वी शुड हैव इंक्लूडेड सम अथॉरिटीज फ्रॉम द हायर एडमिनिस्ट्रेशन, मींस फ्रॉम द गवर्नमेंट, सो दैट वी कैन आस्क फॉर सम, हम कह सकते हैं कि ये चीजें हमें और मिल जाए, तो देन वी कैन इम्प्रूव अपॉन, वी कैन हैव मोर फंडिंग ऑन द हेपेटाइटिस थिंग्स. सो बेसिक पर्पस हमारा होता है कि हम लोगों को अवेयर करें. ट्रीटमेंट के बाद डोंट गेट डिसहार्टेंड. ट्रीटमेंट इज अवेलेबल फॉर हेपेटाइटिस सी का तो मैं कहता हूं कि आज की डेट में विद इन 6 months यू गेट क्योर्ड इफ यू गेट द ट्रीटमेंट. फॉर हेपेटाइटिस बी यू कैन गेट गुड कंट्रोल ऑफ द डिजीज, यू कैन स्लो द प्रोग्रेस ऑफ द डिजीज. हेपेटाइटिस ए और ई तो मुझे लगता है कि ज्यादातर ठीक हो जाती है, बहुत कम मॉर्टेलिटी है. और डी उन्हीं पेशेंट्स में होती है जो हेपेटाइटिस बी या सी से सफर कर रहे हैं. डी अलग से नहीं होती है, जहां तक मेरा जो वो है. तो अगर इसमें हमें थोड़ा सा हम अगर अवेयरनेस का प्रोग्राम और कर लेते तो बहुत अच्छा होता. बट एनी हाउ, एज अ डीन ऑन बिहाफ ऑफ दिस इंस्टीट्यूट, आई मस्ट कॉन्ग्रेचुलेट द डिपार्टमेंट ऑफ हेपेटोलॉजी of SGPGIMS, the organizing team, for this wonderful organization of 2 days workshop symposium on hepatitis, and I wish you all the very best for great success. Thank you.
Thank you, sir. Moving ahead, I would like to invite Professor Rakesh Agarwal sir, Director, JIPMER, Puducherry, to say a few words.
Thank you. Good morning, Professor Deeman, Professor Ambesh, Professor Saxena, delegates for this symposium, faculty colleagues and dear residents and other staff members. The entire purpose, as has been said by Dr. Ambesh, of this day is to make people in different walks of life aware about the problem of viral hepatitis and to see that we are able to do public health interventions so as to reduce the impact on our society, on our population of this disease. Actually, if we look at viral hepatitis, progress has been fairly fast. For those of you who are relatively new to viral hepatitis, it will be interesting to know that if we go back 100 years ago, we never had any idea that there were multiple viruses causing viral hepatitis, that it was not one disease, it was multiple diseases. It was only towards the end of the fourth and beginning of the fifth decade during Second World War, it was realized that there are two forms, serum derived and the waterborne hepatitis. And from there, we have gone on to have vaccines against several forms of viral hepatitis, and we have treatment. So really speaking, the most important thing is to apply these measures. And one thing the gastroenterology, hepatology community has to realize, unfortunately, very often we don't, that we, the gastroenterologists, hepatologists, cannot, and let me repeat, cannot make an impact on this disease unless we involve the wider medical community. We seem to look at from the terminal end, the end product, the person with chronic liver disease. What needs to be done has to be done much earlier. And that's what I think is the focus of our education sessions on this day. And that's possibly what Dr. Goyal had in mind when designing this. Viral hepatitis is a vast field, very difficult to learn in 2 days. I know that because of my interest in epidemiology. In epidemiology sessions, we say there is no part of epidemiology that viral hepatitis does not represent. Bloodborne infections, waterborne infections, person-to-person spread. And if you go to hepatocellular carcinoma, it is virtually like a non-communicable disease. It follows the principles of epidemiology. Screening surveillance follows. So it's a very vast area. But I think the program is well designed to cover most of the aspects. And really speaking, the only message I have for those who are attending this is, please carry this message forward. Don't leave this diagnosis and treatment to the hands of specialists. It has to go to the hands of physicians and possibly to those who are MBBS and maybe even below that. And it's possible to do that. That's the only way we can make a public health impact. I'm sorry, I know I'm a gastroenterologist and I'm saying that it needs to go out of our hands because I'm a gastroenterologist by training, but at heart, I'm a person who belongs to public health. And the principle of public health is that it has to be treated by everybody. We have to have everybody joining hands, otherwise we won't make any impact. Thank you. Sorry for taking so much time. Thank you.
Thank you, sir. Now, I would like to invite Professor Rajan Saxena, sir, Professor Head in the Department of Surgical Gastro, SGPGI, to share his thoughts.
Professor Deeman, Director FGPGI, Professor Rakesh Agarwal, Director Puducherry, Professor Ambesh, Dean FGPGI, Professor Amit Goyal, Head Hepatology, faculty members, delegates. You heard a very detailed description about hepatitis and all phases were covered in these few minutes. I thought I'll touch on something which has not been touched so far. I would like to apprise you of the dirty side of the picture. What can hepatitis B do to a person, and how soon can it do it, or how late it can do it, and what should be the approach? Professor Rakesh Agarwal very brilliantly stated that this is one disease which has to be treated by one and all if we really have to get to terms with it. It cannot be limited to the domain of a gastroenterologist or a hepatologist. Every gynecologist in the trade who is involved with delivering has a reason to look at transmission and attempt to curb it. I'll share with you a small story. 1983, while performing a surgery, I experienced a knife cut. The patient was a case of intestinal obstruction. 7 days post-operatively, he developed jaundice. There was no malignancy in the liver or at the porta. So why did he develop jaundice? It was a cause. And on investigation, we found that he was suffering from hepatitis B, acute hepatitis B. He had never received any blood transfusion, mind you. And that was a time when there was no vaccine, there were no immunoglobulins, and there were no antiviral agents available. For 6 months, I was fine. And then I was stuck. By jaundice, which progressed to 26 milligrams, and I was stuck, admitted to the ICU also. No treatment except for steroids were on the offer. Fortunately, I did something else and managed to get out of it. Became antigen negative, but the insult sustained by my liver made it live only for 25 years. And at the end of 25 years from that day, it was done and over. And I had to get a replacement. I had to undergo a transplant to come back to life again. It is treatable. All this could have been prevented if we had medicines at that point of time to check needle stick injuries and the other things of transmitting hepatitis B. Not there. So what was then and what is now is a totally different story. Today, hepatitis B is something which can be curbed, literally nipping the evil in the bud. At the initial stage, if you vaccinate children, they will not contract it. 97% accuracy, we just heard from Dr. Demon with the vaccination. And if each one of us decides to screen our patients for hepatitis viruses before taking them up for surgery, which is WHO recommendation now, even ophthalmologists do not operate upon their patients without testing for hepatitis B and C. Although there is hardly any blood to be seen in that, but secretions are there on things. So if we take it on us that we will swat hepatitis B and C at the earliest possible, our transfusion services should go above board in screening and giving you the thing. And as physicians, if you pick up liver disease, be very clear. Your patient is going to require medical treatment, and if that does not deliver at the end of the day, he is going to require surgery. So it is clarity in the mind of the treating physician which is going to do the magic. Today, most patients with deranged liver functions are ill-treated, maltreated by GPs and some other physicians, which is injustice to them. I'm glad Amit has organized this program to spread awareness about viral hepatitis. The load is phenomenal because of the huge population that we have. We are number one in the world as far as population is concerned. And with 2.8 to 3% hepatitis load, you can imagine it is in several crores with the number of patients. And each patient has the potential to transmit unless you educate the patient, the public at large, and the physicians themselves get educated in advising the patient about what is to be done. Thank you very much.
Thank you, sir. Now, I would like to invite Dr. Amit Goyal, sir, for a vote of thanks.
Thank you. I like to thank first my director for inspiring us and supporting us for organizing this meeting and helping us to design this program and bringing it to the day of light, and also guiding us through the entire process of hepatology and department coach. Then definitely I would like to thank our Dean for sparing his time on a holiday, and also sir giving you a thoughtful advice which I will try to accommodate in next my meeting. Thank you, sir. It was really a deficiency which I realized today. Dr. Rakesh, he is my teacher, my mentor, whatever I am, largely because of him. Probably just saying thanks to him will be a small word, so I can't say thanks to him. Dr. Saxena, he is the person who has given us this place, actually, you can say. This entire building is his brainchild, and he has given this place where we can gather to here and can talk about viral hepatitis, can learn something, and he is the one who has established liver transplant facility in our state, where, you know, for most of the viral hepatitis patient in context of hepatitis B who are not treated or not controlled will need liver transplant. So really, sir, thank you for establishing this facility and giving us this place free of cost to arrange this meeting and share our thoughts and to some degree train some of our colleagues in the team. Definitely, I would like to thank my entire team, Department of Hepatology, telemedicine people who are helping us organizing it, and everyone who is supporting us. And without your participation, this entire effort is useless. So for participants, definitely I'm thankful for sparing your 2 days, your 2 holidays, and coming here, sparing your 16 hours with us. Thank you.
Thank you, sir. Requesting all of you to stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Now I request everyone for a tea break.
इनके पास है तो भी ये डुप्लीकेट जाएगा। तो आपको पता है ना, बाहर कोई और तो बुला लो। हाँ मैं जा रहा हूँ ऑफिस, वो है ना प्रेजेंटेशन लगा के सॉर्ट करना चाह रहा है कुछ लगाओ।
So welcome back. We will start with the second part of means the continuation of academic activity. And before I move ahead with the, let me share you something. Yeah, so because many of you are coming first time, most of you are coming first time to our department. So just to introduce what is Department of Hepatology is doing and what is master class, what is our idea. So we started in February 2021, almost 2.5 years ago, and we are the first such department, means Department of Hepatology in our state, and this is the 8th department in the country. We have 4 faculty members, all 4 you have seen. 20 beds with 4 ICU bed facility we have as of now. OPD services we are running on 2 days, Monday and Friday, and we have started alcohol use disorder clinic for de-addiction of alcoholic patients, which we felt that is a big deficiency for patients who are having alcoholic liver disease. We are treating liver but not treating alcohol. So that is another initiation we have also started, which will be inaugurated in next week, Alcohol Anonymous Group, further to enhance and support our de-addiction facility in the department for alcoholism. And we have our OPD integrated with pediatric gastro, so it is easy for pediatrics people, those who are transiting to 18 years can easily transmit the patient transferred from pediatric gastro to adult gastro. This is the some additional point for our department. We are active in nutrition. So IPEN Nutrition Group is the Indian Association of Parenteral and Enteral Nutrition, Lucknow chapter. We are officiating Lucknow chapter of IPEN Group, and you can see a poster outside, and we will request all of you to take membership because nutrition is very important, and we are going to conduct more and more activity on nutrition where you can participate and learn about nutrition in your field, not only liver but other field also. So this was one of the training session we had organized for nutrition. In our endoscopy facilities, we are doing regular diagnostic endoscopy, therapeutic upper GI, colon, and this is the metal stenting we have done for esophageal cancer patient. And ERCP facility we have doing for biliary drainage, obstructive jaundice patient. And the additional thing what we have, which is not in any other gastroenterology department, is liver physiology service we have in form of hepatic vein pressure gradient we are doing. Dr. Ajay and Dr. Surinder, they are doing it. And why we are doing master classes is because we have done as a department lots of work on viral hepatitis in public health angle, starting from Dr. Rakesh, Dr. Dhiman, myself, for different countries. So we thought at least we should try to do for our medical student, postgraduate student, because you have to see this patient for next 30 years. So this session is primarily meant to give an overview of viral hepatitis. Feel free to ask questions wherever you want. And we especially want suggestion from medical student, what you want to learn in future, with what workshop we should organize in future. So probably by the end of tomorrow, we will request all of you to give one topic where you want to learn, and we will collate everyone's opinion and try to develop something for you. And I will request you to ensure your correct name, spelling, institute, phone number in your account which you have created in School of Hepatology, because that will be used for your certificate. So please ensure that your phone number, your email, your name, spelling, institute is written correctly. Otherwise, it will be wrong. And I will also request you, your account is created, please continue it, because it will not be chargeable, and you will be keep on getting the information about new meetings, new activity, what we are doing, and a soft copy of your certificate will be available in your account after this course completion, which you can download anytime in life and you can save it. Hard copy will be given to you, one copy, but soft copy you can download for your record. And pictures will also be available on the same account, and you can choose and download whatever picture you want for your record, you can save it. So please continue to hold that account and use it for future. And please keep your account updated. Means today your phone number may be different, but after 1 year or 2 years, your number may change, your affiliation may change. I request you please keep it updated, because that will help us to know that which of my colleagues is sitting in which institute and which state. Suppose I want to do some research on hepatitis B and I want to take a person, a doctor from Barabanki, I will see from the same list that who all are there in Barabanki. So that way it will be helpful, and please try to upload your picture, because when picture is there, we can connect with one-to-one. If there is no picture, we cannot connect with each other. Name, it is very difficult for me to keep in mind name of all the 100 people who are participating here. And one same thing is true for WhatsApp group also, because we will keep on maintaining this WhatsApp group and keep on updating the information. Please do not forget to sign your attendance sheet on both days. You have to sign for 4 times. First half, second half, then second day, first half, second half. Only then certificate will be issued. So please don't think that after half days you will be leave. You can go, and if your attendance is not there on 4 times, and that is why all the 4 attendance will be taken on the same paper, so that I can match that the signature is belonging to the same person. Then you will not be given certificate. Sorry, I am a bit harsh about it, but really it is for your betterment. I want that you should learn. Certificate will be given on the second day, second half, and I want an opinion, because tomorrow we are starting at 9 a.m. So shall I arrange breakfast for you? How many you want that we should arrange breakfast for you? No, because for 9 a.m. many people have to start early, they may not get breakfast. So we will arrange for whatever is available, and those who are not able to take breakfast before coming here can take here. 9 o'clock we will start. Breakfast will be available at 8:30 or 8 o'clock. So who's ever not able to take breakfast, they can take here, no problem. Right? Tea and breakfast. So now we can ready to take off with our academic activity. Our Boeing 737 is ready. Handing over to Ria.
Thank you, sir. Continuing with session 1, I would like to call upon Dr. Surinder Singh, Assistant Professor, Department of Hepatology, to deliver a talk on an overview of viral hepatitis, differential diagnosis, and AVH versus ALS.
Hello, good afternoon, everyone. So after a nice coffee break, we are back. So I will be talking about viral hepatitis, its differential diagnosis, and how the journey from acute viral hepatitis to ALF goes on. So outline would include clinical presentation and definition of viral hepatitis, causes of viral hepatitis, its differential diagnosis, then journey from AVH to ALF. Then I will be talking in brief about certain ALF definitions and then concluding slide. The first and foremost question is why we should bother to learn about viral hepatitis. Why to take so much of pain? So the answer to this question lies in the high amount of mortality which is because of liver cirrhosis as well as acute hepatitis. So you can see because of these etiologies, there is a huge mortality which is seen in the population. Hence, if we can prevent or actually treat patients in time, we can prevent mortality as well as morbidity. So hence the need to learn about viral hepatitis, prevention and timely treatment. So coming to the clinical presentation of viral hepatitis. So viral hepatitis can be divided into two. One is the acute hepatitis, second is the chronic hepatitis. So acute hepatitis broadly is caused by viral hepatitis A, E, and sometimes hepatitis B, whereas the chronic hepatitis, as you know, is caused by B, C, and hepatitis D. So when patient develops acute viral hepatitis, he can progress to acute liver failure, which I will be talking in subsequent slides. And when the patient develops chronic viral hepatitis, he can progress to liver cirrhosis, which in turn may lead to portal hypertension and symptoms, and in turn development of hepatocellular carcinoma. So now coming to the definition of acute viral hepatitis. So acute viral hepatitis can be defined as an acute illness which is characterized by acute onset jaundice associated with dark colored urine, with anorexia, malaise, fatigue, etc., right upper quadrant discomfort, raised urine bilirubin, and serum ALT more than 2.5 times of upper limit of normal. So these are the different phases of illness which are usually seen in acute hepatitis, which is mostly true for all the viral hepatitis illness. So first stage is the stage of prodrome. So all of us are familiar with the prodrome term, which includes symptoms like malaise, fatigue, low-grade fever, nausea, vomiting, aversion to food, mild itching, joint pain, which usually lasts for a few weeks, a few days to a few weeks. Then comes the icteric phase, which is the symptom in which usually the patient presents with yellow colored eyes, dark urine, light colors too may also be seen sometimes. And in this phase, usually the prodromal symptoms gradually subside, and this usually lasts for up to 6 weeks it can last. And third, if the patient recovers, and it is called the convalescence phase, where gradual recovery is the rule. So what does the global data of acute viral hepatitis say? According to the global data, hepatitis A virus is the most common cause of viral hepatitis illness, followed by hepatitis B, E, and C. But this is the global data. When it comes to India, hepatitis A followed by hepatitis E rule the roost, and they are the most common cause of viral hepatitis. So now, what is this term called hepatotropic viruses? I know all of you must be familiar with this term, but let's recapitulate. So viruses that selectively and preferentially target and infect, causing injury to the liver cells, are called hepatotropic viruses. So all of us know that these are hepatitis A, B, C, D, and E. These are the primarily hepatotropic viruses which cause the acute or chronic hepatitis. So now coming to the route of spread of these, so we know that hepatitis A and E is primarily caused by fecal-oral route, whereas B, C, and D are caused by parenteral route, which we know either could be because of unsafe sexual practices or blood transfusion or mother-to-child transfusion. And acute presentation is primarily seen in hepatitis A and E, and primarily B and C will cause chronic illness. However, hepatitis B may sometimes cause acute illness also. A point to remember is that hepatitis E may sometimes cause chronic infection, which is usually not seen in immunocompetent individuals, but in those who are immunosuppressed, for example, those who have malignancy or those who are on immunosuppression like post-liver transplant, or for chronic immunoinflammatory disease like those associated with rheumatology. So those patients can develop chronic hepatitis E. So we know this is a very basic slide, but still we should cover it. That what are the tests for hepatotrophic viruses which we do? IgM anti-HAV, IgM anti-HBV. For hepatitis we do HPSAG, and IgM for anti-core antibody, which is the IgM anti-HBC. And for anti-HCV, we do anti-HCV antibody and antibody testing for hepatitis D virus. So now, after suppose the patient has presented to you with findings suggestive of acute viral hepatitis, you run the panel for viral hepatitis A2 and they come out to be negative. Then do we say that the patient doesn't have acute viral hepatitis and we look for some alternate diagnosis? No, the answer is no, a no, big no, because there are non-hepatotropic viruses also which can cause acute hepatitic illness. And the most common causes include herpes simplex virus, varicella zoster, Epstein-Barr virus, cytomegalovirus, dengue virus, coronavirus, and adenovirus. There are other non-hepatotropic viruses also. Primarily, these are the major non-hepatotropic viruses which you should rule out after you have done a battery of A to E test. So A to E negative, then you should do this second degree of test to rule out these non-hepatotropic viruses causing viral hepatitis. So now the question comes, when to suspect non-hepatotropic viruses as cause of acute viral hepatitis? This is a very pertinent and important question. So the answer to this question is that if the serology for hepatotropic viruses are non-reactive, if patient is immunosuppressed, like patient with HIV or organ transplant recipient, those who are receiving immunosuppression, or those patients who are having prolonged course of illness, like they are not taking too much time to recovery, or the viral syndrome, which is the prodromal syndrome, is less marked. So then also we should suspect atypical viral illness. Then comes level of elevation of liver enzymes. So in acute viral hepatitis, usually those which is caused by the hepatotropic viruses, in those the enzyme elevation usually runs into 1000. So if in a patient OTPT are elevated, but let's say it is 3 to 4 times elevated, and bilirubin is also 4, 5, then you should also suspect non-hepatotropic viruses as cause of illness. And if patient is having any uncontrolled systemic illness, and if patient has recently recovered from any life-threatening infection or sepsis, then these are the conditions where you should suspect non-hepatotropic viruses. So now coming to the differential diagnosis of acute hepatitic illness. So if a patient presents to you with jaundice, prodrome, fever, so what all differential diagnosis you should keep in mind? The first and foremost diagnosis in our country is tropical infection. You know, this is the season of dengue, malaria. So if any patient who presents with acute hepatitic illness, we have to rule out malaria, dengue, scrub typhus, leptospirosis, chikungunya, and typhoid. So differentiation with these diseases must. And how you can differentiate clinically? Suppose a patient has fever, prodrome, and then he develops jaundice. And even after development of jaundice, his fever doesn't subside. This is a subtle marker, and this may be because of tropical infection. Because in usually viral hepatitis, when the jaundice sets in, the fever subsides. So this is an important clinical marker which you can keep in mind, that if fever is persisting despite development of jaundice, then you should keep the possibility of tropical infections in mind. Then second, you can look at this general physical examination. If there is conjunctival suffusion, hepatosplenomegaly, then you can think of malaria and hepatitis. And for scrub typhus, eschar is present. For leptospirosis, if patient has gone outside and has had drenched himself in rainy water and all, then you can suspect these illnesses. So clinical correlation along with meticulous history is important while making a diagnosis and ruling out the other differentials in case of acute viral hepatitis. Second is the other infections like amoebic and pyogenic liver abscess. Patient with amoebic or pyogenic liver may also have fever, jaundice, as well as prodromal symptom. But here he will be having tenderness in his right upper quadrant, and when you will subsequently do imaging, you will find the evidence of liver abscess. Then comes hepatobiliary tuberculosis. So in case patient has hepatobiliary tuberculosis, he can also have acute hepatitic-like presentation, but he will be having other features like anorexia, weight loss, raised ESR, MEN2 test positive, some evidence of extrahepatic involvement like pleural effusion or lung involvement or lymph node on general physical examination. Whereas in sepsis syndrome, if a patient has sepsis because of any cause, he can develop sepsis-related hepatitis, which can also mimic the findings of acute hepatitis. So the first is tropical infection, second one is the other systemic infection and local infection of the liver. The third is the autoimmune hepatitis. So autoimmune hepatitis may also present with fevers like low-grade fever, prodrome, as well as jaundice. But here you will need to ask the patient whether the patient has other features of autoimmunity, whether there is any family history, especially in females, like history of thyroid disorder, diabetes mellitus, vitiligo, or other joint disease. If such history is there, then you will need to do the autoimmune markers. And if autoimmune markers come out to positive, then you will eventually have to differentiate between acute viral hepatitis and autoimmune hepatitis based on the finding of liver biopsy. Because just on the basis of serological markers, it becomes very difficult, because autoimmune markers are positive even in at least 20 to 25% of general population. So once, if you suspect autoimmune hepatitis, then liver biopsy is a must. Then comes the important differential of Wilson disease. Wilson disease in its acute presentation can also present with acute hepatic-like illness. But here you will have findings like patient may have KF ring on slit lamp examination. He may have neuropsychological manifestations. And patient may have evidence of hemolytic anemia, which is non-Coombs positive. So if Coombs test is done, it is negative, whereas the patient is having picture of hemolytic anemia with unconjugated hyperbilirubinemia. Then these findings favor Wilson disease. So then comes another important cause, which is drug-induced hepatitis, which is increasing day by day because of the use of complementary medicine, which is promoted by various departments of the government as well as non-government organizations. So drug-induced hepatitis has to be ruled out in any patient with acute hepatitis. You have to ask the patient whether you are taking any Ayurvedic medication, you are taking any jadi booty. You can specifically ask whether you are taking any Patanjali product, liver 52. All these drugs are known to cause drug-induced hepatitis. So you have to specifically ask. And then one important thing you have to ask in young individuals is whether you are taking any protein supplement, those who go to gym and do heavy workout, because these protein supplements are known to contain contaminants that cause hepatitic illness. So these things have to be specifically asked in history. So last, you have to rule out any poisoning like yellow phosphorus poisoning or any pesticide poisoning. These can also present with acute hepatitic illness. So this you can only know once you have taken a meticulous history and done a physical examination. So this is the broad differential diagnosis of acute hepatitis, which you have to rule out, particularly in our country. So now coming to the journey from acute viral hepatitis to ALF. So by now we know that acute viral hepatitis presents with acute onset jaundice, followed by dark urine, anorexia, malaise, all the features of prodrome, followed by raised urine bilirubin and AST levels more than 2.5. So if the patient is not treated properly at this stage and he progresses, what will be the next stage? So next stage will be the development of coagulopathy. So coagulopathy can be defined if INR becomes more than 1.5, along with the features of acute viral hepatitis. Then the patient will develop acute liver injury. The patient will progress from acute viral hepatitis to acute liver injury if he develops coagulopathy along with acute viral hepatitis. And what will be the next step? Next step will be the development of acute liver failure, which is a very life-threatening condition. So along with the features of acute liver injury, if patient develops any grade of hepatic encephalopathy, the point is any grade, even if grade 1 of hepatic encephalopathy is present in a patient with features of acute viral hepatitis and coagulopathy, then we have to characterize this patient as acute liver failure, and this patient requires immediate ICU admission and very meticulous treatment, and may also require liver transplant if he or she doesn't improve on conservative management. So hence this spectrum has to be kept in your mind, that you do not diagnose and treat patient of acute viral hepatitis progressively. He or she will progress to acute liver injury, and from acute liver injury, we never know, he or she may progress to acute liver failure. So this is the flowchart which you must keep in your mind, whether your patient is having acute viral hepatitis, acute liver injury, or acute liver failure. So now there are various definitions which are available. You must have read in your textbook or any review article. Like there are definitions by O'Grady, Trey and Davidson, by Indian Association of Study of Liver also, and Japanese definition. But the definition which personally I would recommend you to remember is the ASLD definition, which says that any patient with jaundice followed by encephalopathy within 26 weeks associated with coagulopathy with INR more than 1.5 and any grade of hepatic encephalopathy will classify as a case of acute liver failure. So if you do not want to get confused and want to remember single definition, it's better to remember the ASLD one. Although it is up to you, if you are comfortable with any other definition, it's up to you, but I would personally recommend this ASLD definition. ASLD stands for American Association for Study of Liver Disease. So now I would like to give you a brief concept about acute liver failure and acute and chronic liver failure. You must have heard our term of acute and chronic liver failure. So before understanding this concept, I would like to tell that there are two types of liver. One is the liver which is perfectly normal and another is the diseased liver. So if the patient's native liver is normal and he suffers any acute insult like acute viral hepatitis, then he may progress to acute liver injury. And gradually, if he develops hepatic encephalopathy, he will develop acute liver failure. Whereas any patient, because of any reason, chronic hepatitis or alcoholic liver disease has a diseased liver, like he has high fibrosis, F2, F3, which were discussed by Rungta sir previously. So in that liver, if a patient develops acute insult, and along with that, patient develops ascites or encephalopathy, he will be having acute and chronic liver failure because his native liver is not normal. So for a patient to develop acute liver failure, his native liver should be normal. If the native liver is not normal, he will develop acute and chronic liver failure. So these two things you should keep in mind. So to conclude, there are 5 hepatotropic viruses which are well characterized. Hepatitis A and E cause acute hepatitis, which in turn can progress to acute liver injury and then to acute liver failure. Hepatitis B, C, D cause chronic infection, which in turn can progress to cirrhosis and to hepatocellular carcinoma. Non-hepatotropic viral hepatitis is commonly seen among immunocompromised patients, and you should also keep a differential of non-hepatotropic viruses causing viral hepatitis in such patients. And finally, tropical infection causing acute febrile illness has to be a close differential diagnosis of acute viral hepatitis, especially in our country. Thank you.
Thank you, sir. Now I would like to call upon Dr. Amit Goyal, sir, who will be talking on global, regional, and national burden of viral hepatitis.
Thank you. Children. Okay, so in this session we will talk about burden of viral hepatitis. To burden, why it is important. If we don't know the burden, we can't understand the burden, then probably will not realize the importance of the disease. And what is the application to know the burden is how frequently you should suspect a disease. When you have a patient, shall we screen everyone for hepatitis B or C, or shall we suspect hepatitis B in everyone who is presenting with jaundice or without jaundice? If you know the burden, that what proportion of people are having this disease, that will help you to define your strategy for screening, making your suspicion, diagnosis, priority, etc. So hepatitis, as Dr. Surendra told, we have 5 viruses. A and E are enterally transmitted. They causes acute hepatitis. B, C, D are transmitted parenterally, means parenteral route of blood transfusion, unsafe injection, mother to child transmission, unsafe sex. These are the methods, and they causes chronic hepatitis leading to cirrhosis. So global estimate, if you see, you can that hepatitis is causing 1% of global death overall. So means one death in every 100 deaths in this world is caused by hepatitis or its complication. It's not a small number. There are thousands type of illnesses, and hepatitis is counting for 1% of death. Reason why we are talking so much since 2009 and 10 about hepatitis is lying in this slide. If you see, there are 4 lines showing different conditions from 2002 to 2015, the number of deaths due to each of these diseases. You can see death from tuberculosis is reducing. Due to HIV, it is reducing. Malaria is reducing. These are the 3 major global diseases for which actually the global fund is available. HIV, tuberculosis, malaria. Each country is having national programs for these diseases. But what is happening to hepatitis? This is consistently increasing. And even if we stop today, control hepatitis B and C today, this will continue to increase up to 2050 or 2060. We cannot stop this trajectory now because the consequences of hepatitis, what has happened. So that is why world is moving toward hepatitis. And second important point, which is here in this slide, you can see that death of hepatitis has already crossed death caused by malaria and death caused by HIV. And very soon we are going to cross death caused by tuberculosis. So these are the 2 primary reasons why we should know that how much hepatitis is common and what is the burden of disease. This is another important point. Total 1.3 million deaths caused by viral hepatitis, and 96% of deaths are caused by hepatitis B and C. Only 4% of hepatitis deaths are caused by hepatitis A and E. But whenever there is hepatitis, we think it is acute hepatitis, and acute hepatitis is caused by A and E. So we think that most of the hepatitis death is caused by hepatitis A or hepatitis E, but this is not the truth. Most of the deaths are caused by hepatitis B or C. How much? 96% death. And hepatitis A related death, E related death is very small, 44,000 and 11,000. This is the 2015 estimate. If you see that most of the deaths B and C, and where the B and C, how they are causing death? They are not causing death just by infection. They are causing death because of cirrhosis and because of hepatocellular carcinoma. So these are the consequences of viral hepatitis. So we should know that every cirrhotic, every chronic liver disease should be screened for hepatitis B and C. We should take this message from the slide. This is the data on hepatitis A. Just few slides about each virus. These are the red areas which are showing the burden of hepatitis A maximally, you can see, because they are transmitted through enteral routes. So wherever the unsafe food or water is consumed in resource limited countries like Africa or India, South Asia, there the hepatitis A burden is maximum. This is an important slide. Next 4 slides are very important to understand about hepatitis A. This is the typically seen in what is called hyper-endemic pattern. Your x-axis is showing the age of the participant, means the population, and y-axis is showing the proportion of people who are having hepatitis A antibody in their circulation. This is the hyper-endemic pattern which is seen in India and other countries in Southeast Asia region. Means by age of 10 years, you can see 90% of people are already exposed to hepatitis A virus. And that's why when Dr. Surinder told that in adults, the most common cause of hepatitis, acute hepatitis is not A, but it is E. But in children, the most common cause is A. This is the reason. And this is hyper-endemic pattern, means the risk of infection is very high. The advantage in the application of this hyper-endemic pattern is there is no advantage of hepatitis A vaccination to the adults because they are already exposed. So if we have to protect from hepatitis A, we have to give vaccination in childhood, infancy, newborn, to take benefit. Otherwise, they will be exposed. This is the low risk curve, typically seen in developed country, US, etc. You can see here that by age of 30, when the people is their peak of productive age group, the prevalence is something around 20%. So if hepatitis A vaccination has to be given, In Western world, it should be in adult also. This is the difference between the two different type of curves, right? And every other country is lying between them. So we are in one extreme where vaccination for hepatitis A is to be given in childhood, and the US and Europe is in other extreme where vaccination has to be given in adult age also. Hepatitis A epidemiology, burden, etc., prevalence, you can leave it. Then hepatitis E virus WHO document, this was prepared by Dr. Rakesh. Global prevalence. Again, the burden, wherever A is heavy, most of the time E is also heavy. You can see the same thing because route of transmission is same countries. Number of deaths, more of number in understanding. What more you should understand about hepatitis E epidemiology is there two pattern of hepatitis E epidemiology. There are four genotypes, genotype 1, 2, 3, and 4, where genotype 1 and 2 are behaving in one type of epidemiology, and 3, 4 is different. That will come probably in another slide. In India, we have genotype 1. Genotype 1 means it is causing only acute hepatitis and not causing chronic hepatitis. And it is more common in immunocompetent people, means healthy people like us. But genotype 3 and 4 is causing chronic hepatitis. That is why we have kept one session on chronic hepatitis in one of our agenda is there about chronic hepatitis, and it is found in immunocompromised population. So we should understand that two type of HEV. If you come to Southeast Asia region, there are 6-7 region of WHO. India is part of Southeast Asia region, where there are 11 countries. There are 10 other countries other than India, Nepal, Bhutan, Bangladesh, etc. So if you see there, that is the Southeast Asia region, entire green one, the fluorescent green country. Here the 26% of the total population lies in this part of the world. Global population, 26%. And out of this 26%, probably 70% is in India itself. 67% of Southeast Asia region population is in India itself. And another major country is Indonesia and Bangladesh. Other countries are very small. So a specific problem in Southeast Asia region in relation to hepatitis is we don't have finances. We have lack of awareness about its transmission, prevention, and management. We have very limited policy. Now the national program is started. We have no surveillance system, weak estimate of disease burden. We don't know. We don't know how much, how much is the disease burden, and we have very limited preventive services. Water quality and sanitation is a problem. Testing facility for detection of chronic hepatitis B and C. Earlier it was not there, now it is easily available because of COVID. And access to treatment, it was very costly. Now fortunately it is available free of cost through national program. And limited spending on public health, limited allocation of funds. So these are the problem why we don't have hepatitis care in India. These are Southeast Asia region. You can see most of the burden, 62 is chronic hepatitis B, C. It's more of a number. You need not to think about it. This is an important number which you should remember, that what is the prevalence of hepatitis B in Southeast Asia region. In India, which is a part of Southeast Asia region, it is 2%. This is African region, European region, Western Pacific region, and these are the other WHO regions. So in Southeast Asia region, it is 2%. In India, it's something around 3%. So this is the same thing given in chart, that where the maximum prevalence of hepatitis B is in Western Pacific region. We are very away from Western Pacific region, but still our burden is high. In Southeast Asia region, 40 million roughly hepatitis B patients are there, but these estimates are very, very rough. So you cannot rely on them. Hepatitis C, it is 0.5. So two number you should keep in mind, that Hep C prevalence is 0.5, Hep B prevalence is 2%. If you can remember this much, it is more than enough. Hepatitis burden in India specifically, HBsAg prevalence is 2.9% from global burden of disease data published in 2023 or 22, which turns to roughly 40 million people who are infected, means 4 crore people who need HBV evaluation in our country. Very big number. Anti-HCV prevalence is 0.8%, turning to 11 million population. This was my work, which not this one, sorry. This is the global burden of disease data. We're showing the India how much total death caused by various hepatitis A, B, cirrhosis, hepatocellular carcinoma. So this is more of a numbers, need not to remember. Just for the sake of completion, those who are more interested to know about these numbers, they can go back and read. So at global level, hepatitis is a major public health problem and accounts for significant number of deaths. Its death number is increasing, morbidity is increasing. Majority of deaths, majority means 96% of deaths due to hepatitis are caused by hepatitis B and C, and even in B and C, B is taking care of something around 2/3 of the death, and Hep C is 1/3. Prevalence of B is 3.5% and C is roughly 1%. So in India, it is 3% and 1% B and C. If you take Southeast Asia region, it is 0.5% and 2%. We are living in India, so we should know for India, it is 3% Hep B and 1% Hep C. So if you have any question, we can answer at the end of this session. Is the question answered now? What is it?
Thank you, sir. Moving to the next topic, I would like to call Ms. Harshita Katiyar, Senior Research Fellow, Department of Hepatology, HEPGI, to deliver a talk on the serological test of viral hepatitis.
Good afternoon, everyone. I will be discussing upon the various serological markers related to viral hepatitis. Biological diagnosis of a particular disease or a particular infection can be categorized into two types of tests, that is direct and indirect tests. Indirect tests are basically host-based tests, or the host-mediated immunity. That is, we detect antibody in these type of tests, and these types of tests are more sensitive, and they primarily detect recent or the past infection. While in direct tests, we detect pathogen, or we can quantify or detect antigen or nucleic acid. These type of tests are more specific and tells about the active infection. Differentiate between acute and chronic infection. In layman language, acute infection is a period of inflammation or hepatocellular injury that lasts less than 6 months. It is mainly caused by hepatitis A and E viruses, but other viruses also shows acute infection. At the time of acute infection, immunoglobulin M is highly positive. While in case of chronic infection, it is the inflammation or hepatocellular injury that persists beyond a period of 6 months. It is mainly caused by hepatitis B and C viruses. Now, the markers for each and every hepatitis. Hepatitis A markers are IgG anti-HAV. That means it can be due to the past exposure to HAV, hepatitis A virus, or it can be due to the vaccination or the immunity developed due to the vaccination. IgM anti-HAV antibody test means it is due to the recent infection, and total antibody test is also tested with detect and IgM anti-HAV and IgG anti-HAV. Hepatitis B is a spherical and double-shelled structure of approximately 542 nanometer in diameter, having a lipid biomembrane consisting of a hepatitis B surface antigen, which surrounds the nucleocapsid, that is the core antigen, which is complex with the DNA polymerase and the genomic material, that is HBV DNA, that is partially double stranded DNA of approximately 3.2 kb. Now, in this type of hepatitis B markers, we test antigen, antibody, and HBV DNA. Means indirect and direct tests are done. For hepatitis B surface antigen, anti-HBs titer is being done, or antibody against hepatitis B surface antigen is seen. It can be due to the infection exposure of a person to a hepatitis B virus, or it can be due to the vaccination in an individual. Hepatitis C core antigen, it does not appear in blood, it appears in the nucleus of an infected cell. So it cannot be detected, it is not clinically tested. So antibody against it, IgM anti-HBC for recent infection and total anti-HBC for past and recent infections can be seen, can be tested. HBe-AG, that is the E antigen, antibody against it is anti-HBe. It denotes the high viral replication. Apart from these antigen and an antibody, HBV DNA can be qualitatively and quantitatively detected, which are the active markers and are used to decide the need of antiviral drugs. Markers for HCV, anti-HCV, it means a person has been exposed, so it remains positive even after a resolved infection in an individual or the patient that has taken a successful treatment. These antibodies remain active for approximately 20 years. HCV core antigen, it is found when the infection is active. So the viral protein produced only when the virus is replicating. It can be a good alternative to HCV RNA because it is much cheaper and easy to do technique. It becomes negative after the successful treatment. Apart from core antigen and anti-HCV, HCV RNA quantitatively and qualitatively can be detected using real-time PCR. HCV genotyping is being done. Hepatitis C has 1 to 6 genotypes. The sequence variation can lead to varies in sensitivity to some drugs. So it can be helpful in deciding an appropriate treatment in some situations. Hepatitis B virus require hepatitis B virus for its replication. HBsAg positive patients show a close contact with hepatitis B virus patients. HDV infections occurs when it can be due to the co-infection, when HBV and HDV virus simultaneously infect an individual, while superinfection is when a person is having an hepatitis B infection priorly and he gets infected to hepatitis D. For hepatitis D viruses, we mainly detect total anti-HDV antibodies, that is IgM and IgG for recent and past infection respectively. Apart from that, HDV RNA is tested in few cases, but it is not widely used technique because there is no standardization of HDV virus assay. For HEV virus, IgM, that is for the recent infection antibodies are being tested. HEV virus actually shows an acute infection. So these antibodies last for within 6 months of period, while anti-HEV IgG is also tested for those individuals that have been exposed to an infection. Apart from that, HEV RNA is also being tested. In some cases, HEV antigen is also tested. So how do you test the sensitivity and specificity of an assay? A sensitivity of an assay is said to be 100% when all the individuals, for example, if you are having 50 individuals that are having hepatitis C infection, so all of them are tested positive. That is true positive result, and the assay does not give a false negative result. It is said to be 100% sensitive, while assay is said to be 100% specific if all the individuals that has no condition or they are healthy. That is a true negative. An assay that gives all the true negative results and does not give a false positive result. It means the assay is 100% specific. Proportion of those who are tested positive determines the positive predictive value, and the screening tests that give proportion of those who give the negative results are set for determining the negative predictive value. an overview of all the tests that we usually do for detecting all the viral hepatitis J is for hepatitis A, anti-HAV antibody indirect based tests are done. For hepatitis B, antigen, antibody, and nucleic acid tests are being done. For hepatitis C, antibody, antigen, and nucleic acid tests are done. Apart from that, genotyping is done for some drug-based treatment. Hepatitis B, antibody tests are mainly done, not nucleic acid, they are not available. For HEV test, we usually detect antibodies for the past or the recent infection and the nucleic acid detection for the active infection. Thank you.
This session was very important, and why we have kept this session in the very early part, because this is the entire basis of your understanding of next sessions. So if you have any doubt about serological test, what test we are doing and means anyone is doing for patient care in viral hepatitis, please make your doubt clear that what does this test mean. Otherwise, you will not understand when we will talking about hepatitis B, and otherwise you will not get the clear-cut message. At least this much should be clear that there are two types of tests. One is direct test, another is indirect test. Direct test means where we are testing for the evidence, direct evidence of an infection. And those are either antigen test, antigen of the pathogen, or the nucleic acid test, DNA or RNA, right? So if they are present, that means there's no doubt that infection is present, because they will be negative if there is no pathogen. Then second is indirect test, and these are all antibody based tests. And we all know once antibody is formed, it will remain for life. So presence of antibody does not mean that the person is infected. It means person was exposed to the pathogen sometime in life, either today or yesterday. We don't know when. Whether still he is infected or not, we don't know. So this concept is very important. So anti-HAV, and whenever we are talking about any antibody test, it will always start with anti-word, anti-HAV, anti-HEV, anti-HBC, anti-HBS, whatever. If it is starting with anti, it means it is an antibody-based test. It is an indirect test, right? And again, in antibody, there are two types of antibody, either IgG or IgM. IgM means recent infection, acute infection. IgG means previous infection, past infection. So it is very simple to understand, but very important to understand this concept. Otherwise, the entire understanding of viral hepatitis will go haywire. So if you have any doubt, you can ask. That is what Harshita has told, that antibody test means indirect test. Indirect test can be false positive because they can react to any other antigen also. They are devised to act against some specific antigen, but they can act against some other antigen also. So they will be false positive. But false positivity is very less for any direct test. So antigen test, nucleic acid based test will not be false positive, or the chance is very less. But antibody based test is very high chance they will be false positive. So that is why always confirmatory tests are always a direct test. A confirmatory test is never an indirect test. HIV में ही आप देख लो, HIV 1, 2 करते हो, उसके बाद में एंटीजन बेस्ड टेस्ट करते हो या HIV का RNA करते हो, वो इसीलिए क्योंकि वो confirmatory होता है. So if you are having HCV positive and you feel it is false positive, you have to check for HCV RNA. वो अभी HCV वाले स्पेसिफिक सीरोलॉजी वाले में हमने अगेन एक रखा हुआ है सेशन HCV सीरोलॉजी, बट मैं बता रहा हूँ अभी आज की डेट में जो एंटीबॉडी टेस्ट यूज हो रहा है, दो तरीके का यूज होता है. एक या तो कार्ड बेस्ड टेस्ट यूज होते हैं, दूसरे जो एलाइजा बेस्ड हम लोग लैब में करते हैं. कार्ड बेस्ड में तो यू कैन से कि 3 से 5% फॉल्स पॉजिटिविटी का चांस मिल जाता है, फॉल्स नेगेटिव भी मिलता है. जो एलाइजा आज की डेट में है दैट इज मोर देन 99% सेंसिटिव, सो उसमें फॉल्स पॉजिटिविटी का चांस 1% होता है या उससे भी कम है, 0.5% से भी कम आ सकता है. जो ELISA यूज होता है, पर ELISA यूजुअली लैब में यूज होता है। कार्ड बेस्ड टेस्ट इज नॉट एन ELISA टेस्ट। उसकी फॉल्स पॉजिटिविटी 3 से 5% तक होती है। या अजय हटवा दो, ठीक है सर। DNA थोड़ा नकली करो, सुनाई नहीं देगा। हाँ, EAG तो हम लोग कर रहे हैं, कोर एंटीजन तो नहीं कर सकते क्योंकि वो सर्कुलेशन में आता ही नहीं है। ई एंटीजन कर सकते हैं। नहीं, वो कुछ सुनने में गलती हुआ होगा। हेपेटाइटिस बी का कोर एंटीजन जो होता है वो सर्कुलेशन में आता ही नहीं है, तो आप टेस्ट नहीं कर सकते। देख लो स्लाइड, दोबारा चले जाओ, देख लो स्लाइड में फिर से चले जाओ कहीं। Core-related antigen we are not doing presently. It is available in few machines. The best machine is with Abbott, which is their architect. Their model is architect. Now the architect is phased out. They are introduced Alinity. So Alinity is doing it, and few more companies are doing, but the best is with Abbott. And very soon we will be starting core antigen. Next 3 months we will start here. Yes, yes. For B, this is a very good question what Dr. Ajay has raised. For hepatitis B, core antigen never comes into circulation, so we cannot test. So always we test for antibody. If you have to test hepatitis B virus core antigen, you have to do liver biopsy, extract from there, and then you can test. Right? Yeah. Next question answer. So if we have any question related to the previous 3 session or any session started from the morning, we can discuss, and otherwise we can move forward. What's the time? Any सब कुछ समझ में आ गया इसका मतलब, या कुछ भी समझ में नहीं आया? Right? ठीक. So take over.
Thank you, sir. Now I request everyone to head for lunch. बोलो भैया आगे। पता नहीं, मुझे नहीं पता सर, 5 मिनट तो बोला ही, लेकिन नाटक ये क्या है कि मत अभी बोलो 5 मिनट के लिए, बस खाना तो लग चुका है सारा। आज से मौका मिला है। चेंज इन द बैटिंग है ये काटक नहीं है तो थोड़ा इधर बता दे थोड़ा इधर की साइड
ये हटा देना
रहे क्या?
चेक ही तो करना है, ये अपना लैपटॉप लाके कर लो।
एक बार इसको देखते थे, सर जो कह रहे खुल नहीं रही।
ये एपिडेमियोलॉजी पर
सेट करें ये वाली,
नहीं नहीं
यही वाली है खुल तो गई पूरी।
नहीं नहीं नहीं,
अच्छा ये है ना, इसको छोटा करो।
छोटा नहीं, इसने वो डालने की कोशिश की एनिमेशन, और ये एनिमेशन पड़ी नहीं।
इसको पढ़ने के बाद वो आना चाहिए। ये वाली ना सर?
एनिमेशन आया नहीं था, अब आ गया, अब आ गया सर, आ गई स्लाइड, आ गई स्लाइड में एनिमेशन आ गया विद एरो आ गया सर। पहले स्लाइड खुलेगी तो ऐसे खुलेगी, फिर इसके
आप
साथ
दबाएं, दोबारा
एनिमेशन
ही आ
आपका ग्राफ आ जाएगा।
हाँ पेन ड्राइव है वो आप ही की है, मैं निकाल लें। हाँ आपका ही है, तो लगी लगी रहती है।
उसी दोनों डालने पड़ेंगे, दोनों को एनिमेशन में ले लेना। ठीक, हाँ सर, अच्छा बॉक्स छोटा कर दो,
कोई दिक्कत नहीं, बाहर बॉक्स छोटा करता है।
वो ओवरलैप कर देना। ठीक, ठीक है,
यही नहीं है,
वैसे उसी में वो शो तो नहीं करेगा बाद में।
बंद करो, वो कर देगा। ये डाउन करो।
अभी देखते हैं सेव हो गया क्या, सेव हो गया हमारे, चेक कर लेते हैं कौन सी कैसी वाली ना। हाँ, ये तो छोड़ देते हैं उसको, है ना, लगा दिया।
Hello, mic test, hello. Hello, mic test, hello.
So we will restart. We will restart now. Just see, is there anyone in the lunch area? कमलेश उधर देखो कोई है लंच में कि सबको बुला लो. स्लाइड में लाएंगे. So there is little bit of change in schedule. First we will take over hepatitis E virus and then we will go for hepatitis A virus. So there are 3 sessions in HEV. 2 will be taken by Dr. Rakesh and 1 by Dr. Ajay. We will start with that one. Is there any question from the previous session? Yeah or no? So if there is any question from the previous session, we can talk about that, otherwise we'll move forward. अटेंडेंस कर दिया आप लोग ने अपना सेकंड अटेंडेंस किया? हाँ नहीं, सब लोगों ने किया. बाद में प्रॉब्लम होगा जिसने अटेंडेंस नहीं किया, पहले बता रहा हूँ. अटेंडेंस लिस्ट जरूर देना अपना सेकंड सिग्नेचर. सर्कुलेट करा दो, जो नहीं है यहीं पे सर्कुलेट करा दो. एसी बढ़वाया हुआ है.
We are moving to the next session, hepatitis E virus. I would like to call upon Dr. Rakesh Agarwal sir, Director Chipmat Puducherry, to deliver a talk on HIV in pregnant women. Sir, please.
Good afternoon. I'm supposed to talk to you today about hepatitis E during pregnancy. But I believe there has not been any other talk on hepatitis E, so I'll take the first few minutes to talk about hepatitis E in general and then move on to hepatitis E in pregnancy. So hepatitis E is a disease caused by infection with a virus, which is a small sized virus. The virions are icosahedral, and these exist in two forms. Most viruses are either enveloped or non-enveloped, but hepatitis C virus exists in both the forms. And this virus is excreted in the stool of those who are infected, and then it enters the body of the next host by the oral route, so the so-called fecal-oral transmission. And there are at least 4 different genotypes, and that becomes important when we talk of pregnancy. So this is a somewhat old slide, but this is somewhere where I was involved. We try to look at the epidemiology of hepatitis C for global burden of disease study. And this slide shows the parts of the world where over a 27 or 28-year-old period from 1980 to 2007, there had been outbreaks of hepatitis E. And the color or the depth of redness shows the size of the outbreak. And you can see outbreaks were seen in most of the tropical countries, and gray areas are those where there are no reports. So there could either be no disease, no outbreaks there, or those have not been reported. And so it causes outbreaks. Second thing, and some of those outbreaks can be fairly large, as you see in India, China, and some Central Asian countries, and in Africa, there have been outbreaks affecting several thousand people. In addition, it also causes hepatitis, which is not in the form of outbreaks, forming a part of the usual acute viral hepatitis that we see. And here the depth of red color shows the proportion of acute sporadic hepatitis that is caused by hepatitis C virus, with red colors indicating a larger proportion being caused by hepatitis E virus. The virus has 4 genotypes. Of these, genotype 1 and 2 are mainly seen in Asia and Africa, and there have been some reports, 2 reports in 1980s of outbreaks in Mexico, and they were small. So if you see these areas that are shown here in yellow and in this greenish, dirty bluish color, and also these areas, these are the areas where there is genotype 1 or 2 virus seen, and that is what causes outbreaks. Those viruses affect only humans, whereas in the parts that you see the brownish color, that is genotype 3, and that blue on the side is genotype 4. Genotype 3 and 4 viruses mainly are circulating all the time in animals and occasionally cause human infection. So they are different viruses. So genotype 1 and 2 virus are seen in countries where the infection is hyperendemic. It is infection that can, the reservoir is in humans because this virus cannot affect animals, and this leads to outbreaks which can be of different sizes. It also leads to sporadic hepatitis. It is transmitted by water or sometimes possibly through food, mainly affects young people, and there is a relationship with pregnancy. That is our main discussion today. On the other hand, genotype 3 and 4 are very common in animals but does not cause disease in animals. Occasionally, it causes infection in humans, mainly among elderly. This is seen in industrialized countries of North America, of Europe, and that does not seem to have an association with pregnancy. So if I were to tell you about hepatitis C in general, so this is where my association with hepatitis E began, with an outbreak in Kanpur, where there were nearly 80,000 cases. But the interesting thing was that there were 48 deaths, and of them, nearly 1/4 were pregnant women. So that showed that pregnant women are more likely to die than non-pregnant women during an outbreak. And if you look at literature, before that, there had been an outbreak in Kashmir, which had been investigated, and they found that when they did a survey in the field, of the nearly 4,000 men, hepatitis was present in only 2.8% of men and about 2.1% of non-pregnant women. But in the surveyed area, among the pregnant women, the history of jaundice was much more common, indicating that when a waterborne outbreak occurs, pregnant women are more likely to be affected. Not only are they more likely to be affected, that is, they have a higher attack rate, but in them, complicated disease, that is acute liver failure, is infrequent among men and non-pregnant women, but is much more common among pregnant women. Also, there is an association with higher mortality. So 15 to 25% of these pregnant women who have hepatitis die. There is poorer fetal outcomes. So there is more maturity, and there is more fetal death. And these complications are much more common when infection occurs in or disease occurs in second and third trimester rather than in the first trimester. So if we look at this, if we look at the left box as a group of men or of non-pregnant women, and on the right, the box represents a group of pregnant women, infection, whether it occurs more or not, we don't know, but possibly is equally common in both. But among those who have infection, disease, shown here with a yellow circle, is much more common among pregnant women than among non-pregnant women and men. Among them, those who develop acute liver failure is also much more common among pregnant women, and because about 2/3 of them die, deaths are much more common among pregnant women with hepatitis C than among non-pregnant people. This association has not been observed with genotype 3 and 4 disease. Whether it's a difference in the virus or something else, we don't know. It's also possible that genotype 3 and 4 diseases are generally, infection is seen mainly at older age, at which age pregnancy is infrequent, at least in those populations. And also, that disease is seen much more among immunosuppressed people, and they are not the people who get pregnant. Why this disease occurs more in pregnancy, or why is it more severe in pregnancy, we don't know. It could be because of differences in hormonal situation, in immune differences. Some people have talked about that the virus multiplies in the placenta, but each of these remains unclear, and I would say we really do not know as of today why this happens. What does one do in them? Really, we don't have any specific antiviral that one can use in pregnant women. One needs to admit them. One needs to avoid other drugs that are hepatotoxic and manage liver failure as is usual with other patients with liver failure. Yes, if they deliver, one needs to be cautious because of liver injury, they will have coagulation disturbance. There is a higher risk of postpartum hemorrhage. So one needs to give them drugs that will cause the uterus to contract so that bleeding would be prevented. For the baby, one has to watch the baby carefully. Sometimes they are preterm, so you have to do the usual preterm care. You have to watch them for hypothermia, hypoxia, and hypoglycemia, which have been found to be common. Some people have talked about whether we should induce premature delivery. The role of that remains unclear. There is a vaccine, and I think I'll talk about this much more when I come back for the next talk, so I'll skip that here. So how can we prevent severe disease in pregnancy? Sorry, this is the vaccine part. So the messages I have for you is the risk of disease and serious disease among men and non-pregnant women is similar. So it does not change by gender, but in pregnant women, there is a higher risk of serious disease and death, primarily when the infecting virus is genotype 1 or 2. There is a vaccine available, and whether that can be used, I'll talk about that in the next talk. With that, if there are any questions, I can take those up, or I can take those at the end of the session as the organizers please. Thank you.
Thank you, sir. Now I would like to call upon Dr. Ajay Kumar Mishra, sir, to deliver a talk on post-AVH cholestasis.
Thank you. So, starting with my topic. So, post-AVH cholestasis, actually, I have detected the hepatitis A is the most common viral hepatitis we know. So, in viral hepatitis A, we see that more than 90% is spontaneously resolved. And if we see the prevalence of cholestasis is around 10 to 20%, with the incidence less than 10%. This is the overall prevalence. Mean incidence is around 5 to 10% only. The relapsing hepatitis is around 5 to 10% also. This is the prevalence overall, and the permanent hepatitis less than 1%. So these are not very frequent, but we usually see these patients in our OPD and ICU. Those patients, this has been a definition used for the post-AVH cholestasis. This is a very well definition. This is not actually a strict criteria, but usually we use these definitions like peak bilirubin of more than 10 mg per deciliter with the direct bilirubin fraction of at least more than 50% and jaundice duration of more than 12 weeks, along with the absence of hemolysis and renal failure. And ALT levels should be below 500 to diagnose these post-AVH cholestasis. So coming to the natural history of AVH, we see that it starts with the prodrome and there is a ecteric phase, and this subsides in around 6 to 8 weeks, and it becomes to the normal baseline in around 2 to 3 months. So the enzyme levels also come down along with the bilirubin levels in the normal course of the viral hepatitis. But when we see the AVH with cholestasis, there is a plateau phase of the jaundice, and there is a prolonged cholestasis phase, pruritus associated with the jaundice, and it prolongs for more than 3 months, around 12 to 16 weeks, and it is a self-limiting course, but the significant pruritus can be troublesome for the patient. So it is so troublesome that even patients, there are case reports of patients having suicide during the episode of pruritus for the AVH cholestasis. So it is a very troublesome and very significant clinical complication of the AVH. Differential diagnosis to be considered in this phase is most important is drug-induced liver injury, because it is very common to have patients have the herbs for the persistent jaundice, and second is the biliary obstruction. So how we can differentiate between drug-induced liver injury versus post-AVH cholestasis? So drug-induced liver injury will have temporal relationship with the herbal products or any other drugs which has been abused, and also the level of jaundice will correlate with the enzymatic activity. In post-AVH cholestasis, the enzyme levels will come down, but the jaundice persists along with the pruritus. But in drug-induced liver injury, there will be high enzymatic activity along with the jaundice. Second is the biliary obstruction. We need to rule out by the imaging and ultrasonographically. We can rule out the biliary obstruction by the dilatation of the bile ducts. So, which patients will be developing this complication of the viral hepatitis, and what is the possible mechanism? The mechanism is mostly humoral and the precholestatic polymorphism of the hepatocanalicular bile salt transporter. And those patients who have co-infection with viral hepatitis B, along with the older age and high bilirubin levels, and those who have high PT-INR are more susceptible for this post-AVH cholestasis. So coming to a case to make you understand better, the case of 27-year-old male who presented with the jaundice of around one and a half months along with the itching for 1 month, with no history of biliary colic to rule out the extrahepatic obstruction, along with there is no history of fever with chills or any surgery to rule out the extrahepatic obstruction, no history of prior jaundice to rule out the autoimmune hepatitis and other recurrent jaundice, no history of the ascites, encephalopathy or GI bleed to rule out the chronic liver disease, No history of hepatotoxic medications we have to take before diagnosing cholestasis of post-AVH because to rule out the drug-induced liver injury. And also other autoimmune features needs to be ruled out before diagnosing the post-AVH cholestasis. On examination, patient was deeply ecteric. There were scratch marks. So this scratch mark suggests that patient is having severe cholestasis and he must require some interventions for this cholestasis. So patients having scratch mark or having disturbed sleep due to pruritus is a sign of severe pruritus. So there was no cutaneous bleeds, soft palpable liver to rule out the chronic liver disease. Generally, the patients with the viral hepatitis have soft palpable liver. So it confirms our diagnosis, no splenomegaly or ascites, and other systems are normal. On laboratory investigations, bilirubin, which was initially 30, came down to 22. SGOT, PT were also coming down more than 16 times upper limit normal initially, came down to 4 times. And the ALP levels are persistently elevated. Hepatomegaly along with the no ISBRD and IgM anti-HEV was positive. So it was post-AVH cholestasis with HEV positivity. So this was acute hepatitis C, prolonged duration along with cholestasis. So how will we manage? So generally these patients do not require aggressive interventions. We need to monitor the patients and give nutritional therapy along with the supplementations, and the only treatment required is for the pruritus. The pruritus is significant, patient is having intractable pruritus or grade 3 pruritus, we need to intervene. So the first line therapy for pruritus in such patients is ursodeoxycholic acid and cholestyramine. Second line being rifampicin and antihistaminic. Third line being opioid antagonist and ondansetron or sertraline. So drug in the cholestasis are primarily, we do not have data on the post-AVH cholestasis, but the data is primarily based on the other cholestatic disorders. Very little data in AVH-associated pruritus. So cholestyramine, which is a anion-binding resin, which helps in excreting bile acids through the intestine. So we have data on the other diseases, but no data on the post-AVH cholestasis currently. Rifampicin can be safely used in such patients post-AVH cholestasis, and it has been found to be useful in the PBC patients also. So we have experience of using rifampicin in post-AVH cholestasis. It converts bile acids into those metabolites which do not cause pruritus. So non-pruritic metabolites have been, it metabolites to non-pruritic metabolites of bile acids. Anti-opioids, we can use naloxone, naltrexone, or nalmefene. There is reduction in the pruritus score. This data is also again in the PBC patients, although we also have post-AVH patient experience of post-AVH cholestasis in around 15 patients. There was median reduction of pruritus. IV naltrexone has been used, and there is 80% improvement in the cholestasis in patients with the AVH. Ondansetron, although is used in post-AVH cholestasis patients in which there is pruritus associated with the nausea and vomiting, because in cholestasis the chances of improvements are less. So there is a doubtful benefit of adding ondansetron. So in those patients who have nausea and vomiting associated with the cholestasis, we can use this drug. Sertraline also has been shown to have some improvement, around 33% of the improvement in pruritus score with the drug. So ursodeoxycholic acid we are usually use in routine because it solubilizes the bile and it also helps in excretion of the bile, and also it reduces the toxicity of bile acid. So it is very useful for this management of cholestasis. Coming to the non-pharmacological measures, general measures like avoiding the hot weather, frequent cold water bath, avoiding the rough cloth, and avoiding the tight clothing along with the use of emollients can also be useful. Take home message will be very little quality good data for the any drug on acute viral hepatitis associated cholestasis, and most patients resolve with the time, but non-pharmacological therapy may be useful. Rifampicin is the best based on the data from the other liver diseases, but it is risky currently. So other drugs may be tried, but under the careful observation. Thank you. Any questions are welcome. So the competition is actually enzyme inducer. So it converts bile acids to the hydroxyl metabolites of the bile acids. So those metabolites are non-pruritic. So basically the pruritus is due to bile acids, but its metabolite will not cause pruritus. So that's why it works. Yes, we have to monitor. We give only inpatient. We give only to the inpatient, not in OPD. So we frequently monitor like alternate day or twice a week at least. We can give safely because underlying liver is normal. There is no background liver disease. Only there is cholestasis secondary to the viral hepatitis. So we have tried, but still it is risky drug. So we need to monitor it. There are case reports of using steroids also. So, but still there is no recommendation for steroids. In our experience, we have never used steroids for this indication. Cholestyramine is useful. Yes. Thank you.
Thank you, sir. Now I would like to call upon Dr. Rakesh Agarwal, sir, to discuss regarding HEV vaccine.
अच्छा लोग ऑनलाइन है So let's talk about hepatitis E vaccine. So hepatitis E vaccines have been developed. That is because it has been shown that antibodies to the protein that is present on the virus surface, the viral capsid protein, can prevent against infection. So if you take animals, you infect them once with hepatitis E virus, and if you take their plasma, put it into a naive animal, monkey, and then try to infect them with hepatitis C, you cannot cause infection. That shows that the first infection leads to production of something that is circulating in the blood, and it is not cells because we are taking plasma, and that when given into an animal protects against infection. So that means there should be a possibility of making a vaccine. So people have made parts of the viral capsid protein and try to use them for as vaccine. Just like we have made parts, so you're familiar with something called Corbevax. You are so what do we have there? A protein which has been made as a recombinant protein. You give 2 or 3 doses, and the person develop antibodies and they protect. So such a vaccine has been developed against hepatitis E virus. It's called as a HEV-239 on the technical side. It's also available in some parts of the world, as I'll talk later. It's called Hicolin, and this is effective in preventing symptomatic acute hepatitis. This vaccine has been developed by a Chinese university in association with a Chinese company, and the phase 3 trial, a large trial that was done about, so this vaccine was tested in this large study. The eligibility criteria for people enrolled in this study were they had to be adults, 16 to 65 years of age, They could be either male or female, and they took people, they did not test whether they have antibodies to them or not, hepatitis C or not, and they took everybody. This trial was done in China. It was a double-blind randomized trial, means people were either received a vaccine or received a placebo, and this was a field trial which was done in the community, not in the hospital. So what they did was they took nearly 122,000 people. Some people were excluded because they were pregnant, because they had some other illness. 112,000 with an average age of about 45 years, nearly 45% male, 55% female, and nearly half of them had antibodies. Everybody was not tested, a subsection segment was tested, and nearly half had antibodies. They were randomized to receive, half of them receiving 30 microgram of a recombinant hepatitis E virus protein, and the other 56,000 receiving a placebo, which was nothing but a hepatitis B vaccine, and 3 doses were given intramuscularly at 0, 1, and 6 months. Very good trial, because nearly 86% completed the trial, received all 3 doses, and completed a 19-month follow-up. There were some people, about less than 10% each, who received 1 dose or 2 doses and did not receive 3 doses. They also looked at antibody production in nearly 10% of them, and this is what they found. When they followed these people after vaccination for a period of 19 months, 19 months come from 0, 1, and 6 months are the 3 doses. 1 month after the 3rd dose is when you really expect the effect to become fully, and then 1 year follow-up. And the blue line shows the number of cases of acute hepatitis E in those who received placebo, and the red line in those who received the vaccine. And we can see, if we see, a very good trial. So of the 54,000, nearly everybody continued in the trial for follow-up, and there were 21 cases in the placebo group and only 1 case in the vaccine group, showing that there was 95% protection against hepatitis E with this vaccine. So this is just to show you that a very good trial. Nearly everybody was followed up. Even if they did not receive the 2nd and 3rd dose, they were still followed up. And this is the number. Now, if you look at those who took all, that was everybody, whether they took 3 doses, 2 doses, or 1 dose. This is per protocol for people who received all 3 doses and had complete follow-up. We can see 15 people in the placebo group had hepatitis E, and none in those who had received vaccine, 100% protection. An important thing is that among those who had hepatitis in the placebo group, when they tested viral genotype, they found most of them had genotype 4. So the vaccine is made from the genotype 1 virus, but what it protected against, because we can assume that those who were vaccinated would also then have had genotype 4 disease. So what it prevented against was genotype 4 disease. After this initial report, they have followed up people even further. So this is when they had the original data. They have followed people for another 3 years, and those data have also been published. And we can see, so this was the data for the initial 19 months, and you add another 3 years, we have 55 months data, and we can see the number of cases in the placebo group is 53, that in the vaccine group is 7. So from 21 and 1, we are up to 53 and 7. Again, a very high degree of protection, nearly 85% protection at the end of 4.5 years. Longer term data have not yet been published. Also, when they followed these people over time, they tried to look at what happened to antibody titers, like we have done in the case of COVID. So this is a group of people who were seronegative when they were given the vaccine. On this side, on the right side, we have results for people who were seropositive when they received the vaccine. The red line shows people who received 3 doses. This blue line shows those who received 2 doses, that is dose 1 and dose 3. The purple line shows people who received the first 2 doses, did not get the 3rd. And this green line shows people who received only 1 dose. and this bright blue line shows people who were on the placebo group. So we see antibody titers were the highest at the end of 7 months, that is 1 month after the third dose, and thereafter they have declined over time. And we have seen in the previous slide, some cases have occurred among those who received vaccine as time passed. But in those who were seropositive, those who previously had antibodies, the vaccine pushed up the antibody titers, and irrespective of whether they had got only 1 dose, 2 doses, or 3 doses, the antibody titers have continued to be high. So this is like we know for COVID, those who have already had COVID infection, if you give them vaccine, the combined immunity is, hybrid immunity is possibly better. So that is the kind of thing. But no, we don't have further data, and we'll obviously look forward to getting further data. So what is the status of this vaccine? These papers, as you see, are fairly old. This 4.5-year experience was published as far back as 2015. So this vaccine has been marketed in China. It's marketed by a company called Innovax, the one that developed it. It's called by the name Hicolin. There it was licensed in 2011. However, rest of the world it's not available. Only in China it became available. In Pakistan it became available in 2021. It's not yet available in India. It contains a purified hepatitis C virus protein, 30 microgram per dose. It contains some buffers and thiomersal as a preservative. It comes as a single dose syringe, 0.5 ml. You inject it intramuscular. It has to be stored in refrigerator. It has a shelf life of about 3 years and is to be given as 3 doses. This slide, the cost that I have told you, is the cost that was there in 2015-16. And after that, we really don't know what is the cost. This is the cost that was mentioned in a meeting where, as a part of a WHO committee, I was a part of that committee that looked at this vaccine. So this vaccine has been developed against genotype 1, but we've seen in the Chinese trial it protected against genotype 4. We don't know whether it protects against genotype 2 and 3, but possibly it does. At least in vitro data, if you take a cell culture and try to see, it protects against all genotypes. Does it provide complete sterilizing immunity, that if you take the vaccine, you'll never have disease? The answer is no. Already we can see in the 4.5-year data that the antibody titers come down and some people do get infection. And it is also possible that this immunity will depend on how much virus do you ingest. If you get a small amount of viral exposure, it may not cause, it may protect fully, but if you get a large amount of virus, then that will not be protected. In China, it is approved for use in everybody age 16 and above. It is recommended for people who have a high risk of HIV infection, and this is what the package insert means. But the use in China has been very limited. It has not been used much. Who could we use it for? We could give it to everybody in HIV endemic regions like we gave the COVID vaccine, or we could use it for high risk groups such as pregnant women who live in endemic areas. We could give it to people with chronic liver disease who are at a higher risk of serious disease if they get infection, or immunosuppressed persons. It could also be used for controlling an outbreak and given to travelers. Now, use as a general population vaccine, I don't see that happening in my lifetime, whatever you assume my lifetime to be, because we don't know, how much is the burden and whether that justifies. We don't know the duration of protection. What if it protects only for 5 or 7 years? Are we going to give boosters repeatedly to people? Whether it protects. So protection, what it showed was in China, where the amount of circulating virus in water in community is very small. Whether it will protect to the same degree in India, where we possibly have more contamination of water, we don't know. It appears to protect against disease, but does it protect against subclinical infection and viral excretion by humans? We don't know. When do you give the vaccine? The disease is mainly in adults. At what age do you give it? If you give it at 18, do you give a booster every 5 years? We don't know how long the protection will last, and it's going to be, it's costly, and we don't have it available. So the question is moot. For severe disease in pregnancy. Now the question is, there are very little data for giving this vaccine during pregnancy. We don't know. What was prevented with the vaccine was the usual acute hepatitis. Will the vaccine given protect pregnant women against hepatitis C? The severe form, we don't know. We don't know the duration of protection. So if you give it during one pregnancy, do you give it again in the next pregnancy, or will that carry over? We don't know. There is generally a fear of giving anything during pregnancy. So when do you give it? Early pregnancy, mid pregnancy, we don't know. Or should you give it when women get married, or when we think that they are planning a pregnancy? Again, very difficult to determine. Should we give it to persons with cirrhosis? The problem is it produces antibodies in healthy people. If you give it to people with cirrhosis, will it even induce antibodies, leave aside protection? And that's something that we don't know. And again, we don't know the duration of protection, whether we'll need to give boosters. Same is the problem. This is hepatitis E is seen as a serious disease among immunosuppressed people, organ transplant recipients in the West. Again, they are immunosuppressed. If you give vaccine, they don't mount a good response. We don't know. Can we use it for controlling an outbreak? It becomes very difficult when you have to give 3 doses over 6 months. By that time, the outbreak is already getting controlled by itself. So, however, people have tried something very recently. This is late 2022, that in South Sudan, in a displaced persons camp. So this looks like this. It's a flooded area, and this is a camp that the army maintains of displaced people, about 100,000 people living in unclean surroundings. Sorry. Okay. So MSF has launched a campaign because there was an outbreak of hepatitis E in that area. We really don't know whether it's protected, but yes, this has been tried. So it was given to people who were 16 to 40 years of age, because most of the cases were in that age group. If pregnant women were told that we don't have much data on giving this during pregnancy, because the vaccine, the slide that I didn't show you in the previous talk, there were about 50 pregnant women in the trial in China who received hepatitis E vaccine inadvertently, and in them no adverse effects were seen, but that number is too small for us to be able to conclude much. In addition, newer vaccines are being developed. Another Chinese lab has developed a vaccine which is not 239 amino acid, but a smaller protein, 179 amino acids. In animals, it has shown to be useful. In humans, a safety trial, a phase 1 trial has been done. It was found to be safe. Efficacy trials have not been done. And yes, in India, a company, Zydus, has developed a vaccine which is nearly identical to the Chinese vaccine. It's been shown to elicit a strong immune response in animal studies. They have done phase 1 trial in about 23 healthy adults, single dose. It induced antibodies, it was safe. Currently, a multicentric phase 2 clinical trial is in progress. Dr. Amit is one of those centers that is doing this trial in healthy people. And there are other centers in Calcutta, IPGMER, and at JIPMER in Pondicherry. So we are trying to work on this. Not only is this a clinical trial, but piggybacking on that, we are also trying to study cellular immune responses. So to summarize, friends, there is a safe and effective subunit vaccine which protects for around 5 years. It's currently approved in only 2 countries and is not available elsewhere. It's possibly, it should be used, but there are some small questions that remain and they need to be addressed, in particular related to disease burden, cost effectiveness, and whether it will protect those special groups that we want to protect against hepatitis C, the immune suppressed persons, the chronic liver disease people, and pregnant women. So we still need to work out. Things will become easier as newer vaccines come in, and I'll talk to you about another smaller protein that a company in China is trying to develop, and also an indigenous effort in the country. Thank you.
Thank you, sir. Now, I would like to invite Dr. Ajay Kumar Katwa, Additional Professor, Department of Internal Medicine, KGMU, to deliver a talk on extrahepatic manifestation of HEV and chronic HEV.
So good afternoon, everyone. At the outset, I would like to thank Department of Hepatology, SGPGI, for inviting me for this lecture. So after lunch, although Rakesh Agrawal sir has imposed a lot of energy in everybody, but I think the faces are a little bit of tired, and the effect of hyperglycemia post lunch. So let me tease your brain. Before going to the lecture, how many of you are preparing for NEET SS? Are there? I think most of the people are post graduation. Some are practicing clinicians also, and how most of PG students. How many of you have done MD? Apart from the practicing clinician, I'm so sorry, sir. How many of you have done MD? Sir, आप रहने दीजिए. अच्छा ठीक है सर. सर आप. How many of you have done MD? And how many MSc are there? MSc are, how many MSc are there? Right, it's okay. Because that was a purpose basically. Brain teaser number 1. So which of the following sentences is false? HIV is a lone bystander in extrahepatic organ involvement. Causal association is not proven. Number 1. HIV is excreted in semen, but sexually transmitted diseases are not reported. Number 2. Number 3. HIV may cause mild to severe acute pancreatitis. Deaths have been reported. Number 3. IgM, anti-HIV, and HIV RNA should be investigated in all cases of Guillain-Barré syndrome. So option I, which is false? Option A is false. How many? Option A is false. Okay. For B, it's okay. So give any answer. I request you to give any answer. Okay. This may be मिश्रा जी आप ही बता दीजिए. Which is false among them? D is false. Okay, so यहीं पे रहने देते हैं इसको और आगे इन्वेस्टिगेट. So answer is basically how. Let us go ahead. See. Brain teaser number 2. A 35-year-old gentleman with history of renal transplant 2 months ago underwent routine blood checkup. His hemogram, KFT, lipids, sugar, other parameters were within normal limits. LFT showed bilirubin 1.2 milligram, AST 132, ALT 148, ALP 190. He was on prednisolone 20 milligram OD, tacrolimus 3.5 milligram BD, mycophenolate mofetil 300 milligram TDS. What should be the next line of investigation? AST 2 बार लिख दिया सर. एक ALT. सर आई एम सो सॉरी सर. मान लीजिए एक ALT. अच्छा एक कोई भी एक ALT मान लीजिए, एक AST मान लीजिए. आप दोनों ये हाइपोथेटिकल केस है, बट I am ensuring you in the coming future more and more like this cases you are going to see. So routine viral marker, NAT for viral hepatitis in serum, review drugs are all perfectly all right. So at least for this, I think a little bit. Actually, this is a very uncommon topic, and
chronic hepatitis E. Dr. Surinder has a little bit touched the topics, but I think this is usually not discussed a topic. Relatively uncommon to you are all, whoever has said all is all right. So this is the outline of my topic. I will be covering this topic under this following heading. Epidemiology has been covered by Rakesh Agarwal sir in quite a detail. 20 million, according to the WHO 2015 fact sheet, 20 million HIV infection annually, 3.5 million symptomatic cases, 60,000 deaths all over the world. That is huge number. 2015. Now in 2023, it would have gone up. HIV is causing more than 50% of all acute viral hepatitis cases, and it is now proven that it is causally associated with the extrahepatic manifestations a lot. Now, recent concepts within what we have seen within last 2 decades, it may progress to chronicity and very rapidly go to cirrhosis. Specifically, as pointed out by Dr. Surinder, in solid organ transplant, immunosuppressed HIV cancers. First of all, we are going to discuss about extrahepatic manifestations of hepatitis C. So, what is extrahepatic manifestation? Usually, hepatitis E causes infection of the liver, involvement of the liver. So, involvement of any organ beyond liver is extrahepatic involvement. Hepatitis E may involve almost whole body, but the documented cases are in brain, kidney, pancreas, blood cells, joint. HIV has been documented in placenta, breast milk, urine, and semen, but STD has not been documented. So, point number 1 of the MCQ. Among all these, neurological manifestations are most important because these have caused dreaded complications. Extrahepatic manifestations are associated either in the form of prodrome or in whatever form, in up to 90 to 95% of acute HIV and 5 to 11% of chronic HIV also. And causal association has been proved by well-designed studies. In some, asymptomatic lone bystander has been also reported. And what is the pathophysiology of hepatitis E? Why it causes extrahepatic manifestations? The hypothesis has been given or even proven sometimes that it causes tissue tropism. Hepatitis E virus has been detected in various tissues like cerebrospinal fluid, in pancreatic tissues, in other, wherever disease has caused, the people have detected it. Second mechanism is molecular mimicry. So many of the proteins of the hepatitis E mimic with the proteins of the body, and they cause immunological damage to that organ, and that results in the extrahepatic manifestation. So this diagram is showing basically some common. If not treatable, then don't worry. I have discussed in detail. So the largest number is neurological and involving nervous system, both brain, spinal cord, peripheral, pancreas, thyroid, heart, blood cells, kidney, joints. So almost whole body is involved by the hepatitis E. So these are some common phenotypes and some dreaded, very dangerous phenotypes: Guillain-Barré syndrome, neurological amyotrophy, encephalitis, and myelitis. And very well designed studies, case control studies, cohort studies, and case reports have proven that this may cause definite Guillain-Barré syndrome, neurological amyotrophy, and encephalitis. So we are all familiar with the Guillain-Barré syndrome. It causes flaccid parapyresis or even sometimes quadripyresis. 5 to 11% of cases have been clearly documented that they are caused by the hepatitis C. Neurological amyotrophy. When I reviewed, I first time came this term because I had not reviewed the MBBS or MD for neurological amyotrophy. Amyotrophic lateral sclerosis we all have read, so I correlated with that. So when I went into the detail, I found that it involves the bilateral brachial plexus, and it causes various degree of neurological weakness in both upper limbs and shoulder pain. So the series which was described originally was by Dalton et al. So they gave a triad of bilateral shoulder pain, variable degree of neurological weakness, and deranged epilepsy. And they said that all the triad are found almost 100% that cases associated with the hepatitis C virus. Next is encephalitis and myelitis. As with other encephalitis and myelitis, hepatitis E associated myelitis and encephalitis is associated with very poor prognosis. And causal association has been documented by detecting the HEV in CSF and IgM, production of IgM anti-HEV in the intrathecal tissues. 2 deaths have been documented in the case series and case reports. So I think neurological manifestations are clear. Now we are going next to the retinal manifestation. I will finish in time, boss, Dr. Suren. So pathological phenotypes: membranous proliferative glomerulonephritis, cryoglobulinemia, nephrotic syndrome. At least 4 or 5 case series and well-designed cohort studies have been reported on these manifestations, and once again, causal association has been proven. Because as the hepatitis C virus RNA level goes down in the serum, the disease manifestations are gone. And one more thing is to talk about how to diagnose these cases and how to treat. Basically, MPGN, cryoglobulinemia, and nephrotic syndrome are diagnosed as usual. We do workup, urine routine microscopy, clinical features, renal biopsy, and treatment. Most of the cases have either resolved by spontaneously or by since the chronic hepatitis E is present in solid organ transplantation or immunosuppression, or sometimes these are seen asymptomatic in immunocompetent persons also. So either they get resolved spontaneously or switching down the immunosuppression, or in some cases, in 3 cases I found, by giving to ribavirin. So diagnosis and treatment. Hematological. Mostly case reports have been found out detecting anemia, thrombocytopenia, and monoclonal paraproteinemia. So not very large series, cohort or case series. So definite causal association is not proven in hematological manifestation. Acute pancreatitis is a rare complication. In 2015, a case series was published involving 13 case reports, 4 case series, and 55 cases. All were from Asia, and or they had history to the travel to that area. Mean age was 28 years, and male to female ratio were 18:1. So male predominance was there. Mean interval between the onset of jaundice and acute pancreatitis pain was around 10 days, and at least 82% cases were mild to moderately severe, and 18% were severe. 2 deaths were documented. So option number 3. Deaths have been documented in cases of acute pancreatitis related with hepatitis B. Now we are switching over to chronic hepatitis E. So chronic hepatitis E has been defined. Do I need to clear anything in extrahepatic manifestation? Although many other joints are have been documented, but clear-cut large series or causal association has been proven in only these, and all other diseases asymptomatic bystander, lone bystander in case series or case reports have been documented. So do I need to explain anything in extrahepatic manifestation, or switch over to chronic? So chronic hepatitis E is defined as persistence of hepatitis E iron hepatitis E RNA for more than 12 weeks, means 3 months. So, as it's been explained by Rakesh Agrawal, sir, hepatitis E is a virus of genus Hepiviridae, and Hepiviridae has at least 7 species: A, B, C, D, E, F, so on. Among them, hepatitis orthohepivirus A. Orthohepivirus A nowadays has been expanded up to 8 genotypes. Initial 4, 1, 2, 3, 4 have been documented in humans. Rest others have been documented in animals. So now zoonosis, that's the concept of zoonosis. The orthohepivirus C is a pointer. Pointer is this. So orthohepivirus C basically causes infection in the rat, but due to zoonosis, this may cause infection in the humans also. So, and among these genotype 3, 4, and 7, HAV of orthohepivirus A have been associated with the chronic hepatitis B. Only one case of genotype 1 was documented to have chronic hepatitis E, which traveled from Asia to Europe and was on immunosuppressive medications that developed chronic hepatitis E. So one case of chronic hepatitis E in genotype 1 has been also documented. But most of the cases are genotype 3, 4, 7 and one case of rat hepatitis E. Very clearly shown by Sir the epidemiology. Genotype 3 and 4 are mostly found in the European countries, and these have been associated with the chronic hepatitis E also. Genotype 1 mostly in India and the Southeastern Asia region. Genotype 4 in China and Hong Kong all. So the genotype 4 chronic hepatitis E cases were documented in China. Let us see a little bit of review in subgroup of patients how chronic hepatitis E evolved. So epidemiology in immunocompromised patients. So the first case of chronic hepatitis E was detected in 2008 in Europe in post-transplant patients, he was on immunosuppression, and reducing the dose of immunosuppression did not evolve. Then ribavirin was given, and that led to the resolution of the virus. Gradually, then later on, several case series, well-designed cohort and case-controlled studies, which showed that hepatitis E can become chronic in patients in solid organ transplantation in about 60%. In one study in which 14 cases underwent solid organ transplant, 8 out of them went into the chronic hepatitis C. In autoimmune diseases, a review describes 60 cases. Among 67 cases were documented to have chronic hepatitis C on various immunosuppressed medications. In cancer, leukemia, 17 out of 50 cases. In HIV, one case was diagnosed in 2008 after that solid organ transplant in Europe. And later on, 3 more cases have been documented in hepatitis C. Fortunately, after that, even a larger series have not documented chronic hepatitis in HIV. In 2022, 2 cases of chronic hepatitis E were documented in COVID due to the use of immunosuppressive medication like tocilizumab, and one more immunosuppressant was used in Europe, and that patient was developed chronic hepatitis C. So, what are the underlying mechanisms of the development of chronicity? Basically, hepatitis E virus is cleared by the immune system. So, whenever there is dysfunction in the immune response, innate immune system, humoral immune system, due to any either acquired by the immunosuppressive medications or HIV or due to any reason, primary immunodeficiency, that may cause the development of chronic hepatitis C. And it is the severity of immunosuppression and type of mechanism of the drugs used which causes immunosuppression, because not all drugs cause immunosuppression. The most important culprit agents are tacrolimus, everolimus, and rituximab. There are abnormalities in the inflammatory response also, abnormal macrophages, inflammasome reaction, a different concept evolving. Viral factors, genotype 3 and 4, more commonly associated. Tropism for the extrahepatic tissues. Zoonotic potential, quasi-nature. Quasi-nature is a concept. Hepatitis C mutates, not mutates, but it replicates. There are generation of subtypes. Immunity against one type develops, another type does not develop. So persistence. So modes of HIV transmission, mostly zoonotic, blood transmission, and other possible in China. Waterborne, shellfish, fresh fruits, and vegetables have also been documented. As one case which was developed after solid organ transplantation, there was history of eating of shellfish in that. Most of the cases which were detected in Europe has history of zoonotic transmission. So laboratory diagnosis. Very good coverage by Dr. Katia. Sees this. Okay, left. How to diagnose viral hepatitis? So anti-HIV antibodies are usually not useful for the diagnosis of chronic hepatitis C because due to immunosuppression they are not expressed. Nucleic acid testing are reliable both in the blood and stool, and this is the usual sequence of events how the serological markers and clinical features develop after acute hepatitis. HIV RNA in serum up to 1.5 months, in stool up to 2 months, but beyond 2 months HIV RNA is not detected. So persistence of HIV RNA more than 3 months is supposed to be chronic hepatitis C. The case report, case series has seen that chronic hepatitis E may vary from asymptomatic enzyme elevation to frank acute hepatitis to development of chronic hepatitis showing fibrosis, inflammation, and very rapid evolution into the cirrhosis, developing portal hypertension and even decompensation also. Extrahepatic as with the acute we have seen. So how to treat chronic hepatitis E? So first step is reduction. Mostly it is seen in the immunosuppression. So first is reduce the immunosuppression dose. Watch for 3 months. Not cleared, give 3-month course of ribavirin. If negative, well, happy. If relapse after cessation of ribavirin for 3 months, 6 months, and if persist, then in immunotransplant, liver transplant cases, interferon, but not in other transplant, because only in liver cases pegylated interferon can be given. In other transplanted cases, immunosuppression interferes with the pegylated interferon. And if no response or non-response to ribavirin, here also we can use pegylated interferon only in cases of liver transplant. So take home message: many extrahepatic manifestations are causally related to HIV. Initially, it was thought that it only causes acute hepatitis E, but now proven it may cause chronic in immunosuppressed. In near future, more and more, sir is going to start transplant here. Our KGMU has started, but still many knowledge gaps remain. Why one strain causes, another strain does not cause. Geographical distribution, many a lot. So I think this is over, and any question, I'm ready. I will try to explain. अगर नहीं तो बस एक क्वेश्चन मैं पूछ लेता हूँ, अगर टाइम है तो. ओके, सो ये सब क्वेश्चन है तो इनके लिए. अच्छा, ये तो हो गया. इसका आंसर अब बताइए, देखें कितना लोगों ने समझा. The same man, his routine viral markers were negative, but NAT for viral hepatitis A in the serum showed HIV RNA.
I think see, it is injustice to ask questions. Sorry. I am in support of them. This is injustice
Okay, thank you.
to reach to the level of answering a question with the 6 hour session. I think it is injustice. We can leave it. Thank you. So if you have any question on HEV related to anything related to hepatitis C, yes, please. So we have Dr. Rakesh, he can answer any question related to HEV, and we are lucky to have him here.
Listen to your this topic in various sessions. We are very enthusiastic about something. The basic reason it's been there for decades, but there's not so much of enthusiasm in creating a vaccine vis-a-vis, let's say, hepatitis A or rubella with no pregnancy. Why we are not making such deep to hepatitis C vaccine? And only the families are get not so. So on every vaccine. You know, it's a company that has to make nobody wants to make something that will not be there. Right? Either they have to make something that is dirt cheap and it is there. Why is the case is what? You have to make it so cheap that everybody would buy. The problem with hepatitis C is people have tried at the time where people trying to develop a vaccine for more than 20 years. It takes time. Something has been made. But actually the first vaccine I did talk to you about was a vaccine that was developed by the US NIH. It had a trial in Nepal. It was going to be highly effective and it go anywhere because the company decided that this vaccine is commercial. You saw that the vaccines that were developed, mRNA vaccines, I can tell you, this is my conversation with an additional secretary in the Ministry of Finance. I'm into utilization, and this is regarding his conversation with Pfizer. Because Pfizer people, when they contacted them for buying COVID vaccine, they said we have to visit on a time. Finally, they gave 5 minutes time for a senior delegation from Indian government to talk to them. Because they already have that right? Remember, do you know how much the COVID vaccine cost the country? Can anybody guess? I know I'm going again from hepatitis to COVID. Can anybody guess how much the country spent on COVID vaccine? How many doses did we use in the country? Around 2? So about 200 crore doses, right? About 100 crore people were vaccinated. There were 2 crore that forget and some people got the first. How much was it each dose cost? It was bought by the government at about 250 rupees per dose. And the cost of administration is actually even higher. The staff that is there, everything, publicity, etc. So 50,000 crore was the cost of buying the vaccine, and more than that was the cost of administering. Remember, the country's GST collection for a month, till about 6 months ago, used to be 100,000 crore a month. 1 month GST collection was spent on COVID vaccine. Can you imagine what was that? Right? So it costs money, and they realize that the areas of the world where this disease occurs, there is not sufficient money. It's very easy. Somehow, in our country, you have started assuming you are in Delhi. You think that if there is a fire, like in San Francisco, fire brigade should reach your house in 4 minutes. Please forget that we are one of the poorest countries in the world, irrespective of whatever we will say, Shining India or Chamakta Bharat or whatever you want to call it, right? We have to remember that that is a fact. And the more and more vaccines we want to give, then you add it up. If you look at all the hierarchy of diseases for which vaccines are available and should be used, hepatitis C, I work on hepatitis C,
but I also work on vaccine also, so I realize that this is much lower in priority. For us in hepatology, it may appear like a priority. As a country, it is not. That is it. See, what do you perceive is my risk of hepatitis? I'm here in front of you, a 2-year-old man. In the next 5 years, what is the risk that I can get? 50 people around you in the campus, how many people have got hepatitis?
On one hand, we are talking about pregnant women dying of hepatitis.
Right.
And in children also, there is enough literature now to suggest that hepatitis B and B, we have from acute liver failure children are dying.
Actually, so how many people do you immunize to prevent from that? That is the question. And each dose costs $20 and 3 doses cost $60. And if you give it to 1,000 people, do you prevent one death? No, you don't. Public health issues are very challenging. Today morning, in my institute, in the faculty WhatsApp group, a surgeon put up a thing saying, some college of surgeons is saying that any surgeon who opens the abdomen should remove close the fallopian tube, because the ovarian cancer starts in the fallopian tube, not in the ovary. Right? And my question, if I put on my public health hat, do we, how much time is it to practice surgery? And what is it to do the cost? We don't somehow have a solution, we don't think about that. That's what we do. So there are multiple steps. If it is that cheap, then it is there. It's very easy, sometimes it's just I've had in a meeting, which is a common meeting for all sides. And they were talking about developing vaccines for birds. Take avian influenza vaccine. And the chairperson asked the company that was going to make the vaccine, how much will it cost? He said, sir, 1 rupee. Sorry. Okay, let's go to the next. So 1 rupee vaccine, 1 dose. He said, sir, he can buy a new broiler for 5 rupees. Right? At this age and because who will spend 1 rupee per broiler? 1/5 of them don't die. So it comes to volume, it comes to cost. Those are economic, ultimately runs the country, runs the world, not the economic. Sorry, now the rest of the challenge is
Thank you, sir. Moving ahead for the session, hepatitis A virus. I would like to invite Dr. Srish Bhatnagar, sir, Professor Head, Pediatric Department, IRA Lucknow Medical College, to deliver a talk on unique feature of HIV and HIV vaccination. So please.
Thank you to everyone. Thank you, Amit. We started together our journey, and today you are running a school of hepatology. That's a privilege for me and an honor to be here. We just so covering the topic is unique features of hepatitis A vaccine. My contents will be structure and genome, replication cycle, diagnosis, natural history, clinical presentation, atypical variants, and management. So I'll not go into details of all this, but this is just a prelude, is that it's a non-enveloped virus, a hepatotropic picoRNA virus. It has 6 genotypes, and the important thing is genotype 4 to 6 cannot infect the human beings. So we are only worried about genotypes 1 to 3. This is the replication cycle, a very busy diagram, not much of clinical significance. Only thing what we need to understand is that the virus, this receptor, if you see this receptor, HAVCR receptor, this is common for hepatitis A and E. So both hepatitis A and E can enter through this receptor, and that is why the co-infection is common. And chances that if you have hepatitis A, the hepatitis E can also go along with the receptor. And so same comes through fecal-oral transmission. So this is what I just wanted to bring. Okay, now coming to diagnosis. Hepatitis A specific IgM antibodies are typically found in an earlier stages of disease and can last for 6 months. The IgG, we all understand, can last for many years,
and is a marker for previous indication or a vaccination which has occurred. Then there are certain fallacies in IgM, because when we get an IgM anti-HAV report positive, we say that it is acute viral hepatitis, hepatitis A. We do not think about something else, but we need to think about something else, like in a scenario of autoimmune hepatitis, there can be cross reactivity. So a child who is suffering or a patient who is suffering from autoimmune hepatitis, uska antibodies may give a false positive IgM anti-HAV. Then another entity which is now also being recognized is the transfusion associated hepatitis A. And though the risk of transmission is quite less, considering that the life cycle of hepatitis A is small and the whole process of, but still it is recognized entity, and it may be later on screening also in the blood banks may be done. If you see the clinical outcomes of hepatitis A, it is asymptomatic without jaundice, usually in children less than 5 years. Symptomatic with jaundice with self-limited, usually this is the most, if you see a manifestation around 95 to 98%, which we see. Cholestatic is around 5%, then relapsing, and then finally fulminant hepatic failure around less than 1%. So clinical symptoms is primary is asymptomatic, as already discussed. However, what we need to understand is the virus-specific antibodies are usually detected 3 to 4 weeks after infection, and with the occurrence of the antibodies, the fecal release and viral replication goes down. So it is a sign of recovery. This is important in terms of the socio-demographic profile. Okay. This has already been done. This is the natural history of a classical viral hepatitis, which happens. We need to understand this graph. Moynak has beautifully drawn it in his article, which was published. And it clearly shows that whenever we see a case of viral hepatitis, there is importance of prodrome. We need to understand that it always starts with fever, loss of appetite, and vomiting and nausea, followed by occurrence of jaundice. So anything which precedes the jaundice is a prodrome, and this is a mark of viral hepatitis, whereas in cases of other causes of fever with jaundice, like enteric fever, leptospira, dengue, in all of them, the fever and jaundice are coexisting. So very important history when we take any history of viral hepatitis. These are extrahepatic manifestations. I'll not go into detail. However, what we need to highlight is the atypical variants. So atypical variance is any deviation from the classical presentation, and most common atypical presentation is the cholestasis, which is around 15 to 17%, and with hepatitis and ascites and intravascular hemolysis. So I'll be discussing in a few slides what we mean by prolonged cholestasis. So if you see this graph, there is prodrome. Initially, the bilirubin is minimal. The bilirubin starts to rise, but what happens in prolonged cholestasis, the bilirubin tends to remain very high. Earlier, what we had seen is that the jaundice was going down, but at 3 to 6 weeks, the bilirubin tends to remain high, more than 10. The enzymes come back to normal, say around 500 million, which was earlier in 2000s. And once you have these features, you have clinical presentation of pruritus, which is in which you add UDC and rifampicin, which was discussed in HEV also. And finally, there is clinical improvement, and the LFT normalizes by 12 to 16 weeks. So if you see, out of all the cases of prolonged cholestasis, hepatitis A is the most notorious one, which is associated with. The usual period from jaundice to develop itching or cholestasis is around 15 to 30 days. We always need to take history of other causes of intrahepatic and extrahepatic as differential to cholestasis in hepatitis A virus. However, whatever is important history is that we should take also a history of drug-induced cholestasis. Drugs which can cause cholestasis, they can mimic some sort of cholestasis-associated viral hepatitis. Patients are being prescribed drugs for viral hepatitis, which are undue, which is not required. Specifically, I would like to say about the herbal medications.
many of the herbal medications which are given for liver disease tend to induce cholestasis, and that is one of the important features. So UDCA helps in majority. Rifampicin is added in around 20% of cases. As discussed earlier also in one of the questions, steroids may be used, and this is only case series or case which is where we can give prednisolone at 1 mg per kg per day for 2 weeks. These are only case reports where cholestasis. Coming to the next scenario is of relapsing hepatitis. If you see relapsing hepatitis, it is basically there are 2 episodes of jaundice with interval of around 4 to 8 weeks between 2 episodes. These episodes are differential, and it can be monophasic relapse or it can be polyphasic. You can have even 2 to 3 episodes of these occurring together. Duration is from 2 months to 10 months can long last, and LFT abnormalities can persist up to 1 year. So the second or subsequent phases may be icteric or non-icteric. The peaks of liver enzymes may be variable. It can be similar to what the first was, or it can be even higher or lesser. They may have the same severity, less severity, or even go up to liver failure. So the relapse doesn't signify it will be a severe disease or it will be a lesser disease. It can happen anything. So HAV RNAV can be detected, and IgM anti-HAV remains to be present. Differential diagnosis includes AIH, sclerosing cholangitis, Dubin-Johnson's-Gilbert, and very important for pediatric perspective is the hemolytic anemias, which are there. So treatment is supportive with close monitoring. Then the another scenario which comes is acute viral hepatitis with ascites. This is something which we need. This is something which is not usually seen in adult population, but very frequently seen in pediatric population in our context, where we have children coming with ascites. Normally, it was said that ascites means chronic liver disease in adult scenario, but in our pediatric population, it is viral hepatitis. If there is ascites, there can be ascites. And usually what we see is occurs around 2 to 8 weeks, and there is high SAG ascites, and there is no stigmata of chronic liver disease. So it's present in around 13% of cases, which 38% are clinically detectable with high SAG. 11% may have infection. Pedal edema is around 30%. Pleural effusion is around 40%. Risk factors are younger age, lower serum albumin, high prothrombin time. If the child is having all these findings, he may have these ascites which is occurring. Diuretics is required around half of the cases, and they respond well. As the ascites, the resolution of ascites is co-occurrence with the resolution of the liver disease. As just soon as the liver is getting normalized, the ascites is also going down and tends not to reoccur. And finally is late onset hepatic failure. It is the definition wise, if you look at jaundice and encephalopathy should be more than 4 weeks. Ascites is 94% of cases and 50% have HE. Presence of coagulopathy. Ascites can be there normally in also acute viral hepatitis as we discussed, but if the ascites is associated with coagulopathy, means it is late onset hepatic failure. Whereas if it is only ascites with a normal prothrombin time, it is ascites with acute viral hepatitis. So you need to think about coagulopathy as the differentiating. So presence of coagulopathy differentiate late onset hepatic failure from ascitic form of acute viral hepatitis. Again, notorious is hepatitis A. In adults, this scenario occurs in hepatitis B vaccine. Mortality is higher and listing for transplant should be considered. This is one of the scores which is given by the ILBS group, where they said that if the INR is more than 3.1, jaundice to encephalopathy is more than 10 days, and HE grade 3 and 4, this should be listed for transplant. So if you have 2 out of the 3 criteria, this was specifically for hepatitis A, they said that please list in the patients for transplant. So coming to the management, final slide about acute viral hepatitis, hepatitis A. These are the questions which you usually ask. I'm being a pediatric gastroenterologist, so mainly the questions come on from the parents is about
what is the dietary advice, when to admit the patient with acute viral, IV fluids, and specific medicines, what's the role of vitamin supplements, what are liver tonics, when do we need to get an LFT repeat done, and when to return to school. This is a very common question which comes from the parents. So normal diet, no restrictions. The fiction of using glucose, juices, protein restriction, fat restriction should not be there. Prescribe a very normal diet. Even in fact, it has been seen that if you reduce the diet, it leads to longer recovery time. Admit if there's features of hepatic encephalopathy, PT is prolonged or liver size is decreasing. Occasional indications could be persistent vomiting and severe anorexia. Only symptomatic medications are required. No specific medicine is there for hepatitis A. There is no role of any of the drugs as such to be used in a routine case of acute viral hepatitis. No serial monitoring is required. LFT can be done safely after 2 to 3 weeks and after 2 to 3 months to see whether there is normalization of LFT. School, when the child feels so. Usually what we say, the epidemiologists say that the child should return after 10 days because that time the fecal-oral transmission, the child can transmit the virus to the water or is less after 10 days. So they can return, the epidemiologists say 10 days, but otherwise what we say that the child is fine, he's ready to go to school, he can go back even with yellow eyes. So the yellow eyes should not be the criteria to go back to school. So these are my suggested readings. I should recommend that this article by Moinak should be read by everyone who's interested in hepatology and hepatitis. It's a very beautifully drafted article. Can I take my next talk? Yeah. Okay. So the next talk is again on hepatitis, and then come back to hepatitis. We just discussed about upcoming hepatitis E vaccine. Okay. And the questions which was very finely posed, and Rakesh sir answered it very well, that there is some amount of economics into any vaccine. And similar is with hepatitis A, but hepatitis A being more prevalent, the vaccines are there from a long time. So what are the vaccines available in India? I'll try to concentrate. What is catch-up vaccination, which is very important? Something which is like post-exposure prophylaxis, the public health perspective, and is the time right for a mass hepatitis A vaccination. So if you look at, there are two types of vaccines which are available. Inactivated vaccine, these are the companies which are given, GSK, Haverix, Evaxin, Hep B, and HAV Shield. They are all using one similar strain, HM175, 2 doses, 6 to 12 months apart. Intramuscular, started after 12 months of age. Seroconversion, which has been given, is 95% after first dose and 99% by second dose. The median protection is stated to be around 45%. Vaccine efficacy is lower in elderly, immunocompromised, and those with CLD or post-transplant. So if you have to give them before then. More than 85% protected at 50 years of age. They are safe vaccines, only minor local side effects, and very importantly, interchange of brand is allowed if you do not have a vaccine available. So you can change the brand. If there is one you have given first by another, one brand, you can switch over to the other brand if it is required. Coming to live attenuated vaccine, only one is available in the Indian market, which comes by the name of Biovac A, single dose, subcutaneous after 12 months of age. Seroconversion is around 93 to 95% by 30 days. Protection, they say, lasts for around 30 years. Cannot be used, since it's a live vaccine, it cannot be used in immunocompromised and those with CLD and post-transplant. They are safe, only minor side effects. However, if you try to look into the GMC levels, various studies, people have tried single dose of killed vaccine, double dose or single dose of the live vaccine. It has been found that 2 doses of inactivated vaccine is better than 1 dose of inactivated
or 1 dose of live attenuated vaccine at 12 months. So the best protection till now is being offered by the 2 dose of the killed vaccine. So this is what the recommendation is from the pediatric age group. I am trying to say may be offered to all healthy children with special emphasis on children with CLD or adults, chronic hepatitis B or C, congenital or acquired immunodeficiency, transplant recipients, adolescents, seronegative for hepatitis A, leaving home for residential schools, and travelers to countries of high intensity. For catch-up vaccination, it is said that you need to screen for whether you have got the hepatitis A or not. If you have got already hepatitis A infection, there is no need. But if you do not have the seroprevalence, because the seroprevalence is around 50%, then pre-vaccination screening beyond 10 years of age is recommended. This is interesting. Post-exposure prophylaxis, single dose of hepatitis A vaccine, live or inactivated, within 2 weeks of exposure between ages of 1 to 40 years is as effective as giving an immunoglobulin in preventing clinical disease. And the advantage with any vaccination is that it induces active immunity, long duration of protection, ease of administration, and greater availability. However, children who are less than 1 or adults more than 40, if you have an exposure, then IMG at the dose of 0.1 ml per kg, which gives the protection for 1 month, can be done. Coming to the final 2 slides, public health perspective, this is important. What we need to understand is that the hepatitis A was usually considered a disease of children. But now, with the overall changing scenario, what we see is that more and more children beyond the age group of 6 to 5 years of age group, 6 to 10 are getting infection. So the epidemiology is changing. It is moving towards older people, adolescents, older or young adults, the incidence of acquiring hepatitis A. The reason is now India is transitioning from the low endemicity. If you look at low endemicity area or high income regions, their antibody is low, the virus is also low. If you imagine a country like US, there is no virus and there is no antibody. So people are not getting the infection, not they are getting the antibodies. But if you look at another country, say like an African country, they have very large circulating virus, everyone gets an infection and antibodies there in huge amounts. So natural subclinical infection is quite large. What is happening in India with transition, it is called as intermediate endemicity. We have circulating virus. We are not able to go to that level that we are not able to control the virus. So there is circulating virus, but the natural subclinical infection is less. So we have increasing number of clinically hepatitis who are clinically significant. When you get a hepatitis virus infection at 2 years or 3 years of age, chances are it is subclinical. But when you get at 10 years of age, chances are that it will be clinically significant. So clinically demonstrated hepatitis is much more common. Now, can we go to the mass vaccination of Abhi tak? What we've said is that only people who are specially exposed, recommended for all, but can be given to those specific populations. So is the time right for going for hepatitis A mass vaccination? The Argentina model said that when they introduced hepatitis A into their universal immunization program, they reduced the hepatitis A incidence by 80%. So there was benefit. With increasing age of first infection in India, incidence of clinically significant HIV is increasing. And we see that it is causing huge cause of damage like acute viral hepatitis, ALF and ACLF, and atypical manifestations also. So universal immunization is undoubtedly evident in middle income countries with intermediate endemicity, whereas targeted in low endemicity areas. So what is the recommendation is that it should be integrated, but the problems with that we have a large heterogeneous population. We do not have our own seroprevalence data, which is robust. We have limited health funding there, and the cost effectiveness of mass program is still unsure. So these are my suggested readings. Please go through them when you have time, and thank you for patient care.
Thank you, sir. Now, I would like to call upon Dr. Sumit Rungta, Professor, Head Gastroenterology, KGMU, to deliver a talk on epidemiology of HIV.
Good afternoon, everyone. My talk is reversed in order, so most of the slides in my talk is already covered by Professor Sri Svatnagar sir. But I will again tell you something because it is very important to understand the epidemiology of hepatitis A virus also. I will cover my talk in following points: introduction, virology, modes of transmission, people at risk of HIV infection, and burden of viral hepatitis A infection and disease. Hepatitis A virus is a member of hepatovirus family placed in the family picorna viridae. It is highly endemic in Indian subcontinent. Hepatitis A virus usually causes subclinical infection or acute self-limiting disease, but may cause acute liver failure or fulminant hepatic failure in some cases. Hepatitis A virus is a icosahedral virus. Size is about 27 nanometer. It is non-enveloped virus. It is having positive stranded, single-stranded long RNA genome with codes for a single polyprotein of approximately 240 kilodalton size. Hepatitis A in childhood is generally asymptomatic infection and provides long-term protection. Due to significant recent improvement in sanitation, some pocket of population no longer infected at the earlier age group, so results in the paradoxical severe disease in adolescent and young adults. People living in urban area and high socioeconomic status having high risk of infection in adults. This is the graph which is showing the development of symptomatic disease and age of acquisition of the hepatitis A virus. In India, usually, which is considered as a high endemic area, more than 90% cases infection occur at the age of less than 5 years. This is the US data in which incidence rate of reported HIV infection is in this graph. It shows that young adults aged 20 to 29 years have highest incidence of HIV. This is the green line, which is showing the highest incidence rate between the age group of 20 to 29 years, and children 0 to 19 years of age having lowest incidence rate of HIV, which is a goal of 2020 goal of to achieve the low incidence rate lower than 0.30 cases per 100,000 population. It is equally men and women have similar incidence rate of HIV infection. Men have slightly higher rate, but usually it is similar between male and female. According to race, Asian and Pacific Islander have highest incidence rate of HIV. Non-Hispanic, Black and American Indian persons have lowest incidence rate of HIV, and both groups already met the 2020 goal of 0.30 cases per 100,000 US population, as it is shown in this graph. Mode of transmission. It is usually transmitted by fecal-oral route, person-to-person contact, or by ingestion of contaminated water or food. In HIV infection, person-to-person transmission is usually less common, but in HIV, person-to-person transmission also occurs. Parental route of transmission is very rare. Cyclical outbreak occurs in the person with IV drug abuse, non-injection illicit drug use, and men who sex with the men. People at increased risk of, these are the high risk group for HIV infection. Those are international travelers, men who sex with men, people who use substances like IV drug abuse, people facing homelessness, people anticipating close personal contact with the international adoptees, and people at occupational risk of exposure. These are considered the high risk group for the hepatitis A virus infection. What are the person who is having high risk of severe diseases? The person who is infected with either hepatitis B, C or HIV, cirrhosis, person who are having cirrhosis of any etiology, or persons with autoimmune hepatitis or alcoholic liver disease. If superimposed HIV infection occurs in that could lead to acute liver failure, acute or chronic liver failure. Global incidence of HIV is about 100 million cases per year worldwide. About 15,000 to 30,000 deaths occur per year due to hepatitis A virus. Most of the HIV burden occurs in the low and middle income countries. Whole of the world is divided into the high, intermediate or low endemicity zone on the basis of there are multiple classifications used to classify countries into various groups. The oldest classification in which if the 50% population is having anti-HIV antibody, then it is considered as a high prevalence, high incidence group. If 15 to 50% population is having anti-HIV antibodies, then it is considered in intermediate group. And if less than 15% of person having anti-HIV antibody, it is considered a low incidence zone. Another classification is, which is usually used, is high, intermediate, low and very low prevalent country. If at the age of 10 years, 90% of the population develop antibody, then this country is used, this country or area is called as high prevalent zone of the hepatitis A virus. For the intermediate zone, if at the age of 15 years, nearly about more than 50% population is infected, this area is considered in the intermediate zone. If at the age of 30 years, more than 50% population is infected, then this is the area of low. And if less than 50% person are infected at the age of 30 years, then this is the area of very low endemicity of hepatitis A virus. This is another classification which is used in European Center for Disease Prevention and Control. This is also showing high, intermediate, low and very low according to the cases per lakh population. In this graph, the red area, India and Africa, is the high endemicity area for the hepatitis A virus. That means at nearly 90% of the population is exposed to hepatitis A before the age of 5 years. If less than 50% population is exposed to hepatitis A at the age of 35 years, that is shown in this zone. So in high endemicity area, this graph is showing at the age of 5 years of the age, more than 90% of the population is infected with the hepatitis A, and they already developed antibody against the hepatitis A virus. In country with the poor sanitary condition and low socioeconomic status, this type of patterns occurs. In intermediate endemicity area, in countries in transition from low socioeconomic status to the improved housing and hygienic condition, mainly specific segment of the population. Pediatric population may escape HIV infection and at the early childhood. So they did not develop anti-HIV antibodies. So susceptible individual is infected by HIV at the later stage, that is in the adult and adolescent age groups. HIV infection associated with high proportion of more severe clinical manifestation as compared to subclinical presentation in babies. So this graph is showing intermediate endemicity of the hepatitis A virus. Low endemicity, The risk of acquiring HIV infection is very low for the general population. Risk is higher in individual belonging to a specific risk group. Epidemiological shift from high to intermediate endemicity of HIV observed in many countries, especially those with the improving socioeconomic and sanitary conditions. These transitions result in the individual susceptibility to infection, leading to increase in disease incidence later in the life, with consequent increased disease severity despite the presence of improved socioeconomic and sanitary conditions for part of the population. बेसिकली इतनी बातों को बताने का ये मतलब है कि यूजली जब हम लोग प्रैक्टिस करते थे शुरू में, तो हेपेटाइटिस ए के इन्फेक्शन के केसेस हमारे एज ग्रुप में जो पॉपुलेशन हम लोग 18 इयर्स के अबव की देखते हैं, उसमें कॉमनली नहीं मिलते थे पहले. लेकिन जैसे जैसे टाइम बीतता जा रहा है, सोशियो इकोनॉमिक स्टेटस कंट्री का इम्प्रूव कर रहा है, तो एडल्ट्स में और एडोलेसेंट में एचआईवी के केसेस काफी देखने को मिलने लगे हैं. This is the global disease burden 2015 estimate. Viral hepatitis causes nearly about 1.3 million deaths in year 2015, and only 0.8% are deaths caused by hepatitis A virus. Rest of the deaths are most common cause of death is hepatitis B, followed by hepatitis C. Hepatitis E causes less than 1% deaths. This is again in this slide is showing deaths. 78% deaths occur due to chronic hepatitis and 22% deaths occur due to acute hepatitis. Out of which only hepatitis B is the most common causes in acute hepatitis, leads to nearly about 57% of deaths, and hepatitis A causes nearly about 6% of the deaths. This is the one article showing increased burden of hepatitis A in adolescents and adults and need for the long-term protection. This study shows 12.5% of the suspected viral hepatitis were caused due to HIV. Among children and adolescents, most cases were caused by HIV. Majority of cases were in the southern region, and higher HIV positivity rates were found during the monsoon season. This is the most important line. From 1909 to 2003, it was found that HIV infected person has decreased in 5 years, nearly about 75%, and increased in 6 to 15 years of the age group. This is also the mortality data, in which hepatitis A causes nearly about 6,000 deaths out of these deaths. Thank you. Any question?
Thank you, Sumit. So we have basically completed the basic concept of viral hepatitis burden, hepatitis E on hepatitis A. This much we have covered till now. Now the main crux, you can say, hepatitis B and hepatitis C is left. So before we move ahead, because both of them are chronic hepatitis and probably the most important part of hepatitis when we come across to real life practice. If you have any question related to hepatitis we have learned so far, we can discuss, we can answer question, and then we can move forward. And hepatitis A, just one thing I want to add what Sumit and Shirish has told. Whenever hepatitis A occur in adults, then it causes more severe disease as compared to children. There is high risk that patient will develop acute liver failure as compared to children. So as our financial condition, economic condition is changing, more and more adult people are being exposed to HIV and they develop acute hepatitis A, so more death. And that is why this vaccination concept are more important in Western countries, because their adults are not exposed. Most of the acute hepatitis A develop in adults in Western world, so they are more concerned about vaccine because the productive life goes. And here the most of the vaccine preventable HIV occurs in children, which just causes acute hepatitis, nothing more than that. So this is one of the major difference we should realize why hepatitis A is different between how it is different between and what is its application. So we have any question? Otherwise, we can take tea and we can come back and start few session of Hep B today. And majority part of Hep B will be tomorrow, followed by Hep C. And if you have any question again at night, if you question, so just enjoy tea, a short break, and then we'll come back again.
ये ओपन कर सकती हूँ। हाँ, अपने ऐसे चल रहा है। एक मिनट। हाँ, बस है ना? ठीक है। ठीक है, आपके तो डबल आ रहा है ना? दो से सही है। ठीक है।
Hello, Michael. Hello. 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 Hello.
बुलाओ बुलाओ। अजय बुला के लाओ यार बाकी को, अगर कोई है तो देखो। So we are left with 3 lectures related with hepatitis B. First, we will talk about the epidemiology, virology. This lecture has most important part is burden. Already we have talked. Epidemiology already we have talked. Nothing much. You have to focus here is virology. If you don't understand this virology part, it is very difficult to understand what are the markers of hepatitis B virus, like E antigen test, anti-HB test, 4 antibody, HBS, and the newer marker like quantitative HBsAg, HBV DNA. So those things are very important if you understand the concept of virology, followed by the test and then natural history. Hep B is a DNA virus. The important thing is this is the only hepatotrophic virus out of the 5 which is a DNA virus. Otherwise, all other viruses are RNA virus. And there is a basic difference between the RNA virus and DNA virus. 2 types of viruses, like basic difference is RNA virus will survive in cytoplasm but will not go inside the nucleus of the hepatocyte. But DNA virus will move inside the nucleus and get integrated with human DNA, and that is why DNA virus persists for life. And that is the reason out of these 5 viruses, only hepatitis B virus persists for life once infection occurs. No other hepatitis virus persists because A, C, D, and E all are RNA viruses. So this is an important concept which we should understand why hepatitis B is not being cleared and others are cleared. DNA is partially double-stranded DNA. It's more of a theoretical interest and does not contain any practical value for us. If we see the serum in electron micrograph, we will see 3 types of particles here. Yeah. So this one are the yellow ones, are the cylinders. This one you can see the spherical one, but we can see something greenish inside. Something, and these are the homogeneous things. These are the empty particles. So there are 2 forms, spherical and cylindrical. And in spherical there are 2 forms. One is empty and one is complete particle. So total 3 types of hepatitis B virus circulate in our body whenever it is present, right? It will become more clearer here. It is shown here. So these are the 3 different forms. This is the cylindrical form. This is the empty circular form, and this is the complete particle, which is called as Dane particle. We have learned that in Dane particle we have surface antigen. This one. Then we have another coat of protein which is called made up of core protein, HBV C antigen, which is called as. Then if there is a DNA which is partially double-stranded, and we can see that the DNA is broken here. That means it is partially double-stranded. It is not completely double-stranded, and this thing is DNA polymerase. So this is the entire structure. Another point which you should probably next picture you can see. Yeah. So in our body, means that a person who is hepatitis B infected, number of spheres are much more than the number of filaments. So this is the most abundant form. This is the second in number, and this is the third in number. Right? So empty spherical form is most abundant, followed by empty
filamentous form followed by the complete Dane particle. Out of these things, only Dane particle is infectious, other two are not infectious. So whenever in early days hepatitis B vaccine was made from human serum, at that time these two were used to make vaccine, because they are not infectious particle. You can just harvest it and use it as a vaccine. It will induce immunity. Second important thing is empty envelopes are in large excess, means 100 to 10,000 fold, not 1 to 3 fold. Means on an average 1,000 fold their concentration is as compared to complete particles. So if you have one Dane particle in our body, there will be 1,000 empty filament or sphericals circulating in the body. This is the point which we need to understand when we are testing for quantitative HbSAg test, which is a fancy test. Many times we are seeing report. Quantitative will test everything. So even if DNA is negative, you don't have even a single Dane particle, even then quantitative will be positive. That is why it is not a very good test. You're getting my point or not? That is the application. Quantitative HbSAg will quantitate all the HbSAg which is present here. It is present here also, and here also. Even if you don't have this particle, even a single particle is not there, your HbSAg will be positive. You are getting my point? That is why quantitative HbSAg is not a very good test, right? And DNA is a better test because DNA is present only in this one. Yeah. This is another thing, just for the sake of completion, that the length of the filamental particle is variable. This is the structure. Yeah. Here is another important concept which I want to give you. You can see there are three types of proteins. These are the three types of particles which we have just learned, and there are three types of particles. This is one. This is the second. You can see the two protein here, and this is the third type of protein. 1, 2, and 3 components. So there are three types of components, and they are called as small surface antigen, medium surface antigen, and large surface antigen. So this is the medium made up of 2 components. This is the large made up of 3 components, and these are the small. Small and medium are present in large amount, but the number and the quantity of large surface antigen determine which type of particle will form. So that is very important. So you have 3 types of hepatitis virus circulating in the body and 3 types of surface antigen. We are telling it is surface antigen, but it is made up of 3 different types of protein: small, medium, and large. And out of these 3, small is present in maximum number, followed by medium, followed by large. And inside the core, again, another protein code, which is the core antigen, which is never comes into circulation. Then we have DNA. Now, this is the third important concept which we should know. In hepatitis virus, quite complicated virus, but this is the gene. But we are not bothered about it. You leave it. That what's the shape of genome. So I am just leaving it as it is. But this genome have 4 types of open reading strains. This is the first open reading strain, you can say, which has pre-S1 component, pre-S2 component, and S component. This is the second polymerase, which gives rise to polymerase, DNA polymerase X, and then we have 3, 4, and 4. So there are 4 open reading frames. What is the importance of them? You will understand in next slide. What is the central dogma? Anyone knows? MD वालों को तो पता होगा अभी सबको ना. What is the central dogma? Always from DNA, RNA is formed. What is called as transcription. From RNA to protein is formed. What is called as translation. And if we go in reverse direction, this is called reverse transcription, right? So that is the central dogma. So whenever there is from DNA to RNA formation, RNA to DNA formation, start codon is AUG, always. Always protein synthesis start with AUG, which codes for methionine. This will be the first amino acid whenever any protein synthesis happens in our body. And this is the three-stop codon, UAG, UA, UGA, or corresponding is TA, UG for DNA, RNA. So whenever these three codon will come, protein synthesis will stop. And where first methionine will come, protein synthesis will start. This is how it happens and how it is translated in our body. Let us see in hepatitis B. So this is the pre-core and core region you have seen. We have just shown in previous slide. We have two starting points. One is here and one is here. And there is the stop point. So if by chance protein starts from here, it will end there. Right? This is called core region. And this will form core antigen. But if protein synthesis starts from this end, then it will form the longer protein, but it will stop at the same point. And then it will form E antigen. This is how the same gene in hepatitis B virus is producing two different types of protein. One is core antigen and one is E antigen. Getting my point? Am I clear? This is how two things is happening. Same thing is happening here in case of this gene. S gene pre-S2 and pre-S1. You have 3 points where protein synthesis can start, but it will stop in the same point. Stoppage is fixed, but starting is different. So if it starts from here, it will form a small surface antigen. If it starts from middle one, it will form medium surface antigen. And if it starts from here, it will form large surface antigen. And obviously, naturally, anything which is small is easy to form. That is why small surface antigen is maximum in number and larger one is the smallest in number. Right? It has no, it has no clinical significance. As of now, what is the known clinical significance is that why I have explained is because I wanted to emphasize on quantitative HbSAg, because that is the test which everyone is doing, but they don't know what the quantitative HbSAg is. Quantitative HbSAg will measure small also, medium also, and large also. But what is of significance is large. We can't do. As of now, we don't have any test to differentiate between them. So what is important is surface antigen testing, fine, then DNA. But quantitative HbSAg को पेशेंट को आप देखोगे ना, आज खुद ही कराता रहता लाल पैथोलॉजी से, सर पिछली बार 5000 था, अब 4800 ही रह गया है, घटता रहता है सर, अब फिर बढ़ गया. एवरीवेयर अवेलेबल सर, 500 रुपये में होता है बाहर. हाँ हाँ, आराम से होता है क्वांटिटेटिव HbSAg. नहीं, डीएनए तो थोड़ा महंगा है, 1500 में हो जाता है, इसीलिए उसका अल्टरनेटिव लोग सरफेस एंटीजन यूज करते हैं कि क्वांटिटेटिव HbSAg कर दो. बट क्वांटिटेटिव HbSAg इज अ यूजलेस टेस्ट. दैट्स व्हाट आई एम टेलिंग. दैट्स व्हाई आई हैव एक्सप्लेन्ड दिस थिंग. एंड this is the virology part, and so we have this kind of combination, different protein, which section is forming this one. Then HPV replication, not much to understand. See, complicated life cycle, it goes, enters, then goes into nucleus. What important is, once goes inside the body, it forms cccDNA, it remains inside the body, but this cccDNA is not replicating, it is staying there, and it is producing these 5 types of RNAs, messenger RNA. This cccDNA is producing 5 types of messenger RNA, which is coming out into the cytoplasm and producing all the components required for hepatitis B virus replication. Why we need to know this thing is all the drugs which we are using in present era hepatitis B virus, they act in this thing. They are not acting anywhere. And that is why even after 10 years of hepatitis and drugs use and DNA suppression, virus is not cleared from the body because it is not affecting DNA. That is still there. That stage has crossed. Drugs are working here. So it is hampering the development of new virus. But whatever is inside, it is not clearing it. That is one message I want to give. Second important message is, see, it is affecting DNA growth. So the particle which is containing DNA, only that will be affected. But I have shown we have 3 types of particles. only one contain DNA. So out of these 3 particles, drug is are working actually only against one type of particle, not the 2 type of particle. Anytime. That is the reason that whatever drug we have, they are good to suppress DNA, but they are not good to clean the hepatitis virus. Bacteriostatic, exactly. So जब तक हमें ये बेसिक कॉन्सेप्ट नहीं समझ में आएगा, हम उस ड्रग को नहीं समझ सकते कि वो कैसे क्यों नहीं कर रही है. 5 साल खा लिया फिर भी नहीं क्लियर हो रहा वायरस. And that is the reason even after 10 years of drug use, quantitative HbS does not go down, because it is inhibiting only synthesis of one type of particle, which is present 1 in 1000. 999 particles are not affected by this drug. So quantitative HbS will remain high. So cccDNA, yeah, just for theoretical purpose, because we have talked about genotype of hepatitis E, hepatitis C we will talk, and A. So HBV have 8 type of genotype. In India, the most common genotype is D. So if you summarize, I will take opportunity, especially for PGs. For hepatitis A, the most common genotype is 1 in India. Hepatitis B, it is D. Hepatitis C, it is 3. Hepatitis E is 1. All the 4 viruses you can keep in mind. This is the global burden. As I told, 2.9% prevalence of surface antigen in our country. And this is the most common cause for cirrhosis and hepatocellular carcinoma in our country. This is the all basic crux of this session is the virology, how it replicates and what are the different components and what is the surface antigen, different type of particles. So if you have any question, we can, otherwise can move. Okay, so shall I move forward? नींद के लिए adequate material है ना आप लोग के पास? Hepatitis B. So again the same particle, surface antigen. So basically it is double coated virus. First coat is made of surface antigen, which are of 3 types: small, medium, and large. Then the second coat is made up of core antigen, which never comes in circulation, only antibody appears. Inside that we have partially double-stranded DNA and we have DNA polymerase. This is the test which we are using. So what Harshita has taught us, the 2 type of test, direct investigations or indirect test, what we say. So these are the direct tests in context of hepatitis B virus. Surface antigen, you can understand what is the source, what it is testing. So if surface antigen is positive, that is a stronger evidence that the person is positive. It is more specific. Core antigen, E antigen. These are the 3 antigen we can test. Core is practically tested only in liver tissue. It is never tested in circulation. So you have to do liver biopsy, extract the from the cell, and then you can test. For antibody, we are testing antibody against surface antigen is anti-HBs. As I taught in the morning that all the antibody name will start with anti. Anti-HBC will be against core antigen. It will can be G and M both times. IgM means recent infection, acute hepatitis B. IgG means old infection, prior exposure. Then anti-HB is antibody against E antigen. And nucleic acid type of test is DNA. DNA can be 2 types, qualitative and quantitative. Qualitative का मतलब क्या हुआ? हाँ, present या absent, नंबर नहीं आएगा कोई, only present और absent, है ना? वो अब नहीं होता कहीं, अब कोई नहीं करता, because वो पहले जमाने में quantitative महंगा होता था तो qualitative किया जाता था. So अब केवल quantitative use होता है. क्वांटिटेटिव के कॉन्टेक्स्ट में मैं एक पॉइंट और बता दूं यहाँ पर कि जब भी क्वांटिटेटिव का रिजल्ट आता है, यू शुड always count result in term of international unit per ml. Sometimes some labs are giving result in terms of copies per ml. So if you have to convert it, divide your copy number by 5 and you will get result in international unit per ml. Of E and NT. That will come actually in I think तुम्हारे वाले टॉक में आएगा ना अभी E एंटीजन और एंटी वो तुम्हारा नेचुरल हिस्ट्री वाले में आएगा शायद ना, नहीं आएगा तो मैं बता दूंगा अभी। तो उसमें क्या है बेसिकली E एंटीजन, इफ यू natural history, if you follow the hepatitis B natural history, then in early stage DNA will be very high, E antigen will be positive, antibody will be negative. Then DNA will come down, E antigen will come negative, and antibody will appear. If antibody has appeared, that is a stronger evidence that person will not relapse back. Now his virus has gone into quiescent phase. But if antibody has not appeared, only E antigen is negative. It means if you stop the drug, again he will go back to the E positive state. That is the significance of E and anti. That is why most of the time we are doing both the tests. So, yeah. So HPSAG, I don't think there is anything new in this, what I have told already. Only thing what you have to know in HPSAG that if after acute infection HPSAG persists for more than 6 months, it is counted as chronic hepatitis B. Anti-HBs can appear after natural infection as well as after vaccination. So to differentiate whether this anti-HBs is due to natural infection or this is due to effect of vaccination, we have one test, that is IgG anti-HBc, which we had just learned. If IgG anti-HBc is positive, then you can think that anti-HBs which has appeared is due to natural infection and it has cleared now, an antibody has appeared. If IgG anti-HBc is negative and history of vaccination is present, then you can think this anti-HBs is because of vaccination, right? So that is the use. Productive level of anti-HBs is considered more than 10 milli-international unit per ml. And what is important is once it is more than 10, you need not to retest it. You need not any booster. Even if become undetectable, you need not to do anything. We have follow-up data up to 35 years. Core antigen, you can leave it. ENT, DNA. So whenever hepatitis B virus enters inside our body, it can cause either acute infection or it can cause chronic infection. Who will develop acute and who will develop chronic is primarily determined by one factor, that is the age of the person at which he was infected. At less than 1 year of age, 95% will develop directly chronic hepatitis. They will never develop acute hepatitis, right? 1 to 5 year of age, 20% will develop acute hepatitis, 80% will go to chronic hepatitis. After the age of 5 years, especially in adolescent and in adults, 95% will develop only acute hepatitis and 5% will progress to chronic. So that is the age which determines who will develop acute and who will develop chronic. In acute infection, it can be asymptomatic. It can be acute viral hepatitis or acute liver failure, as Dr. Surendra told. Acute viral hepatitis, acute liver injuries, acute liver failure. Same thing is happening here, but this is because of hepatitis B. Yes, sir. That is not true, sir. I still have no answer. Even I asked this question to very big people. Same newborn is not protecting himself from the virus, but same newborn is developing very strong reaction against the vaccine. Why? I don't know. It's the same newborn. Vaccination, it is producing very nice immunity. But why it is not protecting against virus, I don't know. Probably it is the effect of in utero exposure. Probably. Because the body becomes insensitive. Then chronic infection. First, it is a natural history. When we talk, it is a chronic infection. It progresses to chronic hepatitis B. Different phases of chronic hepatitis B, which Dr. Surinder will talk. Then progresses ultimately to cirrhosis. Cirrhosis will have first compensated stage, then decompensated stage, and can have hepatocellular carcinoma. So what happened to the serological pattern following acute hepatitis B infection? Just I have tried to summarize. This is the on x-axis you can see the time from exposure, and y-axis is the relative concentration or the amount of a pathogen. You can see, and this is surface antigen. So after exposure, surface antigen concentration goes up, and then it will clear in 6 months of time. And after that, anti-HBs will appear. Right? This is clear. And this is how the IgM will appear. So soon after acute infection, when HBsAg positivity will appear, very soon after that, IgM will appear, and it will become negative. After that, IgG will appear. Right? So total IgG alone is not tested. It is always total anti-HBc is tested. So that is why it will keep on going up and it will persist. And it is the same antibody which is produced by your natural infection. This is the relation of E antigen. Initially it is high in concentration, then it clears and anti-HB will appear. So this is how, if you follow a patient every day with test, the different tests will go show you this pattern of quantity with time. And this is a little bit of exercise. If you have HBsAg is negative, anti-HBs both are negative, person is never exposed. That means, obviously, if HBsAg is negative, total is positive, and anti-HBs is positive, what it is? Natural infection. Why it is natural infection? Because this one is positive. And if total is positive, anti-HBs is negative, past natural infection clear, but anti-HBs has either not appeared or it has cleared. Kuch bhi ho sakta hai. And that is the antibody, vaccination induced. So it is the interpretation of different type of, this is how we interpret. We have all the values of investigation, and then we interpret and make conclusion, what is the status of my patient. Here, antibody is present. IgM is also present, means recent infection. And please mind, when IgM is present at that time, total will definitely be positive. It is not possible that IgM is positive, but this is negative. That will 100% be positive. And so on. Acute infection, which is still ongoing, not resolved, means early stage, and it is the chronic stage where you will have total anti-HPC positive and surface antigen. This is the last stage where we are getting most of the patients. So it takes actually a bit of exercise to see your 10-20 patients, interpret your data based on these guidelines, and then your mind will start working that way. So this is the whole summary of and possible interpretation of different serological markers which we test. In summary, HBsAg positivity means it could be an acute infection, it can be chronic infection. If IgM is positive, it means it is an acute infection. HBsAg, if persists for more than 6 months, it is likely to be chronic infection. If anti-HBs is positive along with core antibody, that means it is a natural infection, and likewise. So for HBV screening, we are using HBsAg surface antigen, and for this is the first test we are doing or anyone is doing. If HBsAg is positive, then we test for E antibody, E antigen, and HBV DNA. So if you have any question, I can try to answer. Otherwise, next we can. Yeah. If person is HBsAg positive and he is vaccinated, its vaccine will not work. It will be a wastage of vaccine. But because vaccine is cheaper and testing is costlier, that is why it is advised that don't test for prior exposure, just give it to everyone. अब सर वो एक्चुअली गाइडलाइन तो हमारी नहीं कहती अभी आज की डेट में, तो आई विल नॉट से कि हर किसी को वैक्सीनेट करो, वैसे भी 40 के बाद वैक्सीन का रिस्पांस पुअर हो जाता है। तो मैं ये नहीं कहूंगा 65 से ऊपर सबको करो, लेकिन अगर कोई हाई रिस्क प्रोफेशन में है तो उसको डेफिनेटली कर देना चाहिए। अगर कोई 65 प्लस है फिर भी हॉस्पिटल में काम कर रहा है तो वैक्सीनेट कर देना चाहिए। ये
Thank you, sir. Now I would like to call upon Dr. Surinder Singh, sir, to deliver a talk on natural history of acute and chronic HPV infection.
नहीं दूसरे वाले
So finally coming to the last lecture after a long tiring day. So I promise that I won't take more than 7-8 minutes, and so that you people don't curse me. So coming to the natural history of acute and chronic hepatitis B infection. So starting from the slide which sir showed in the last presentation, so hepatitis B infection can be either acute or chronic depending on the duration. So if less than 6 months, it is actually acute, which can be asymptomatic, acute viral hepatitis or acute liver failure, whereas chronic can manifest as either chronic hepatitis B, which can in turn progress to compensated decompensated cirrhosis and in turn into HCC. So this has already been discussed as acute hepatitis. So same is the case for acute hepatitis B also. It will be having 3 phases: prodrome, ecteric and convalescent phase. I think by now you must have understood, so no need to repeat this. So now, how does acute hepatitis B progresses naturally? So 70% of the cases of acute hepatitis B will be subclinical or have ecteric hepatitis. They will be having either no symptoms or mild symptoms at the best. Whereas 30% of the patients only will develop ecteric hepatitis, that is, they will have jaundice and raised AST, ALT and INR. Whereas only less than 1% will progress to acute liver failure. And as told by sir in the previous presentation, that age at infection and immune status of the host factor determine progression from acute to chronic hepatitis B. And chronic hepatitis develops only in less than 5% of adults and approximately 95% of the infected infants, meaning that those who get infection at birth will have a higher chances of chronicity. As we can see in this, that those who get the infection at birth will have higher chronicity. Whereas as the age increases, the level of chronicity decreases. However, one thing to remember is that those who will get the infection at birth will be relatively asymptomatic, and those who get the infection at adulthood will be symptomatic, but they will clear the infection, and only 5% will progress to chronicity. So this point is of importance. So now, acute versus chronic hepatitis B. So clearly speaking, as an epidemiologist, we are more interested in chronic hepatitis B. Why? Because it causes long-term morbidity and mortality, and also it is a reservoir for transmission. So if we do not treat it, it will keep on propagating the epidemic of hepatitis B virus, and we will keep on having the mortality and morbidity associated with chronic hepatitis B. So acute liver failure has told that only 1% of patients developing acute hepatitis will progress to acute liver failure, and we already have understood by now that presence of acute liver injury along with any grade of encephalopathy defines acute liver failure, and this is a life-threatening condition and may require liver transplant. So how to differentiate between acute viral hepatitis and acute liver failure? Just for revision part, prodrome can be present in both, sudden jaundice present in both, OTPT can be raised in both, IgM anti-HBC can be positive in both. However, encephalopathy will be absent in acute viral hepatitis. Coagulation may be slightly drained on mean normal, whereas it will be more than 1.5. A liver size, it is actually in acute viral hepatitis causes hepatomegaly, all of us know, and in acute liver failure, because of the necrosis of the cells, shrunken liver will be seen on imaging. So this is all about acute. Now coming to the chronic hepatitis B. So chronic hepatitis B, the natural history actually depends on the host immunity and the virus, and both of them are at a war, perpetual war, and whoever has the upper hand actually determines that the patient has what stage. Although this is not entirely true, there is second school of thought also that virus doesn't play any role and immunity has a predominant role, but let's not go into the controversial part. For simplicity, we can remember that it is a duel between the virus and the host immune response, and depending on the upper hand of either the host immunity and the viral hepatitis, the manifestation will be seen. So natural history of chronic hepatitis B, we can actually divide it into different phases. First is the immunotolerant phase, second is the immune active phase, third is the inactive carrier phase, and fourth is the HBs AG clearance or cure. And then there is one reactivation phase, which I will be explaining in the subsequent slides. So this picture beautifully shows the natural history of the patient. The first is the immune tolerant phase. In immune tolerant phase, as the patient has, let's say for example, a child has acquired hepatitis B from his mother, and then the patient is in immune tolerant phase, meaning that although the DNA levels are high, but the immune response to the virus is not there. So if there is no immune response, there will not be any destruction of the liver cells. So hence ALT levels will also be normal. So although HBV DNA levels will be high in such patients, but ALT levels will be higher, meaning that there is no destruction of the liver cells by the host immunity. So hence there will be minimal activity and scant fibrosis. And once we progress to immune active phase of chronic hepatitis B, so here there will be a continuous fighting between the liver cells and the virus cells, so leading to fluctuating hepatitis B DNA levels as well as the AST ALT levels. So here activity will also be there, active hepatitis will be there, and variable degree of fibrosis may be seen. So once this fighting has subsided, so when the body has subdued the virus, so the level of virus will decrease and the activity will also settle down. So this is the inactive carrier stage, meaning the activity is also less and the DNA levels have also come down. And then there is the reactivation phase. So inactive carrier phase doesn't mean that the virus has been eradicated from our body. So anytime a patient, if his immunity wanes or the virus gets activated because of any immunosuppressive drugs or any other acute insult or mutation in the virus, so there will once again be reactivation of the virus, and once again the patient's immunity and the virus will fight the war which they were waging previously, and then once again the OTPD level will fluctuate and DNA level will also fluctuate till either the cure occurs, that HBsAg loss occurs, or the patient once again reverts to inactive seizure. So I hope you have understood the natural history of the hepatitis B, that starting from immune tolerant phase to immune active phase, then inactive phase, and then there is risk of reactivation. So now coming to the serological markers in chronic hepatitis B in different phases. So in immune tolerant phase, AST/ALT level will be low, HBV DNA will be high, HBeAg will be positive because the virus is proliferating, and HBe is a marker of proliferation. Anti-HBe will be negative, and there is no need for treatment. Why there is no need for treatment? Because the virus is not causing any damage to the liver cells, so no need of treatment. Then comes the immune active phase. Here, immune active phase, as there is the ongoing war between the cells and the virus, so AST/ALT will also be high. HBV DNA will be high or moderately elevated. HBeAg may be positive or negative, and so is the case with anti-HBeAg. Because if the patient has seroverted from controls the infection, then HBeAg will become negative, and patient will convert to anti-HBeAg. However, in immune active phase, either of these pictures can be seen. So in inactive carrier phase, ALT level will also be low, HBV DNA will also be low because the virus proliferation has been controlled. HBeAg and anti-HBV may either be positive or negative depending on whether patient has seroconverted or not, and there is no need of treatment in inactive carrier. Whereas in immune active phase, we have to treat the patient. Then comes the reactivation. So in a patient who previously had inactive carrier, reactivation occurs, then AST/ALT will start increasing. Initially they will be low, and then they may go to the moderately high level. DNA level will subsequently rise, and in reactivation also we require to treat the patient with antivirals. So this is the pictorial representation where a native liver, which is normal, develops chronic hepatitis B infection, and then subsequently, because of the different insults, will progress to chronic liver disease and then liver cirrhosis. And once liver cirrhosis sets in, then liver cirrhosis is a fertile soil for hepatocellular carcinoma, and 6 to 8% of the patients with liver cirrhosis per year will develop hepatocellular carcinoma. One thing to remember is that a patient who doesn't have cirrhosis and has chronic hepatitis B, he can directly progress to hepatocellular carcinoma because the hepatitis B virus also releases some oncogenes which can cause hepatocellular carcinoma without going into this stage of liver cirrhosis and then carcinoma. It can directly cause hepatocellular carcinoma. Hence, hepatocellular carcinoma screening is required in patients with chronic hepatitis B infection. So to summarize, hepatitis B infection in infants or small children has a high risk of progression to chronic infection. Hepatitis B infection in older children or adults results in acute hepatitis with spontaneous clearance. Chronic hepatitis B passes from different stages, progression to cirrhosis and then subsequently to hepatocellular carcinoma. Patients with cirrhosis can develop decompensation and liver-related death. Liver cancer can occur even without cirrhosis, as I told. And among persons with chronic hepatitis B infection, only those with elevated ALT and high HBV DNA level need treatment. That is, those who are in either immune active phase or those who have reactivated. Thank you. So this was the last session of the day, and tomorrow we will be starting at 9 a.m. and breakfast will be ready at 8:30. So we wish to see you at 9 a.m. sharp for tomorrow's session. Thank you.
Thank you for being with us for the whole day. I know it was a tiring day, and I guess at least you would have learned something, if not everything. We don't expect that you will keep everything in your mind, but at least you will keep something in your mind, and you will have a good overview of viral hepatitis. Beyond that, sky is the limit. Whatever you want to learn, whatever you want to practice, it's up to you. We are always available for any further clarification or interaction anytime, even after these 2 days. So see you tomorrow, and thank you.
क्या करता है